Hello, everyone. I'd like to call the meeting to order and welcome everyone in attendance. The committee has under consideration the estimates of the Ministry of Mental Health and Addiction for the fiscal year ending March 31st, 2025. I'd ask that we go around the table and have members introduce themselves for the record. Minister, when we come to you, if you would kindly introduce your colleagues at the table, that would be appreciated. We'll start to my right.
My name is Andrew Bochenko, and I'm MLA for Drayton Valley, Devon.
I'm Eric Bouchard, MLA for Calgary Lougheed.
All right, good evening. Brandon Lunty, MLA for Leduc Beaumont.
Chelsea Petrovic, MLA for Livingston McLeod.
Scott Sear, MLA for Bonneville Cold Lake St. Paul.
Good evening, everyone. Peter Singh, MLA Calgary East.
Okay, thank you. To my left, I have my Chads. I have Chad Mitchell, Assistant Deputy Minister, System Overview and Strategic Service Divisions. And then I have Chad Schultz, Assistant Deputy Minister, Financial Services Division. And then to my right, I have my Deputy Minister, Evan Romano, and my Assistant Deputy Minister, Policy and Program Division, Corinne Everington. And I am Minister Dan Williams, Mental Health and Addiction.
Hello, I'm Luann Metz, MLA for Calgary Varsity.
Diana Batten, MLA for Calgary Acadia.
Good evening, Janet Aramenko, MLA for Calgary Currie.
Good evening, Nicole Goring, MLA Edmonton Castle Downs and Deputy Chair of this committee.
My name is Jackie Lovely, and I'm the MLA for the Camrose constituency and the Chair for the committee. Now, I don't think we have any members participating remotely, so I'll just skip to the housekeeping items here. Tonight we have Mr. Bochenko substituting for Mr. Long. Thank you so much. Please note that the microphones are operated by Hansard staff. Committee proceedings are live streamed on the internet and broadcast on Alberta Assembly TV. The audio and visual stream and transcripts of the meeting can be accessed via the Legislative Assembly website. Please set your cell phones and other devices to silent for the duration of the meeting. Honourable members, the main estimates for the Ministry of Mental Health and Addiction shall be considered for 3 hours. Standing Order 59.01 sets out the process for consideration of the main estimates, and Legislative Policies Committee Suborder 59.016 sets out the speaking rotation for this meeting. The speaking rotation chart is available on the committee's internal website, and hard copies have been provided to the ministry officials at the table. For each segment of the meeting, blocks of speaking time will be combined, but only if the minister and the members agree. If debate is exhausted prior to 3 hours, the ministry's estimates are deemed to have been considered for the time allotted in the main estimate schedule, and the committee will adjourn. Should members have any questions regarding speaking times or the rotation, please email or message the committee clerk about the process. With the concurrence of the committee, I will call a 5-minute break. Does anyone object to having a break this evening? Okay, midway through we'll have that break. Ministry officials who are present may, at the direction of the minister, address the committee. Ministry officials seated in the gallery, if called upon, have access to a microphone in the gallery area and are asked to please introduce themselves for the record prior to commencing. Pages are available to deliver notes or other material between the gallery and the table. Attendees in the gallery may not approach the table. Space permitting, opposition caucus staff may sit at the table to assist their members. However, members have priority seating at the table at all times. Points of order will be dealt with as they arrive, and individual speaking times will be paused. However, the block of speaking time and the overall 3-hour meeting clock will continue to run. Any written material provided in response to questions raised during the main estimates should be tabled by the minister in the assembly for the benefit of all members. Finally, the committee should have the opportunity to hear both the questions and the answers without interruption during estimates debate. And members, please, debate flows through the chair at all times, including instances when speaking time is shared between the member and the minister. I'd now like to invite the Minister of Mental Health and Addiction to begin with your opening remarks. You have 10 minutes, sir.
Well, thank you very much, Sharon. And thank you for your hospitality and having me here today, and to all members for engaging in the process. I understand you've had a long day, so hopefully we'll get through this efficiently together. So before I get things started, I want to introduce again on the record for Hansard the officials I have with me. I have my Deputy Minister, Evan Romano. I have Chad Schultz, my Assistant Deputy Minister, Financial Services Division. I have Chad Mitchell as well, my Assistant Deputy Minister, System Overview and Strategic Services Division. And then I also have Corinne Everington, Assistant Deputy Minister, Policy Programs Division. So, In mental health and addiction budget for 2024-25, our government is laying out a clear commitment to supporting mental health and wellness for Albertans and supporting them in the pursuit of recovery. We have a plan to continue building the Alberta recovery model. As we invest in programming and infrastructure that will give children, youth, and Albertans of all ages the opportunity to access the service that they need, whether it be in a school setting, live-in treatment program, or mental health counseling, as examples. At the same time, we are in the process of placing more focus and oversight on mental health and addiction services delivered within our provincial healthcare system. This year, mental health and addiction budget totaling more than $1.55 billion includes $1.3 for services currently delivered within AHS. This funding will have designated oversight from the Ministry of Mental Health and Addiction and will be used to support the continuation of services within the new Mental Health and Addiction Agency being developed as part of Alberta's healthcare refocusing. The result of our budget will continue to support treatment and recovery, children and youth services, prevention and intervention, and many other pieces of the Alberta recovery model. And I look forward to diving into these as part of today's meeting and our questions. When our government was elected 5 years ago, we made it clear how we would be responding to the addiction and increasing levels of mental health challenges in our province. The fact is, any person suffering from mental health challenges or from the deadly disease of addiction deserves an opportunity at recovery. I'm grateful to have the opportunity to carry that now as I serve as Alberta's Minister of Mental Health and Addiction. When discussing topics such as addiction, I think we as policymakers have to decide which road we are going to take, whether it be the Alberta model or the Vancouver model. As we have been warning for many years, radical programs like so-called safe supply have turned into harm production instead of harm reduction, as they feed addiction and flood the streets with opioids more and more powerful than heroin. Instead of taking this road, our government is following the evidence-based approach and the moral approach of treatment and recovery, giving people suffering from addiction a hope and a new lease on life. This is what we are building in Budget 24. With funding for recovery treatment centers, same-day opioid agonist therapy, and the ongoing operation of more than 29,000 treatment spaces, a total capacity increase of over 55% since 2019. This represents 29,000 opportunities to receive services such as detox and residential treatment for Albertans. Funding in this budget will enable us to move forward with real infrastructure like recovery communities and other facilities to support the well-being of Albertans. I was able to visit the recovery community in Red Deer recently, which houses 75 Albertans seeking to receive addiction treatment at zero charge to themselves. This is significant, as historically residential addiction treatment centers in Alberta have cost thousands upon thousands of dollars for an Albertan to attend. Instead of making cost a barrier to someone's recovery and their second lease on life, our government has looked at addiction treatment as a healthcare service, fully funding it across the province, ensuring someone's financial situation never prevents them from receiving the life-saving treatment they need. Facilities built in direct relationship with the Blood Tribe, Siksika Nation, Tsuut'ina Nation, and Enoch Cree Nation are examples of how our government is working with Indigenous communities, overcoming the addiction crisis and filling the void left by the federal government. In all my conversations with chiefs and leaders, the message I hear is very clear, and what they want and need is recovery, not addiction facilitation model of the federal government and the so-called safe supply. Facilities built in Calgary, Grand Prairie, Edmonton, and Gunn will be making addiction treatment programs more accessible to communities across our province, with one more location yet to be announced. In total, these 11 facilities are adding another 2,000 treatment spaces per year to give Albertans life-saving treatment that will not only help them overcome addiction, but also help them become productive members and contributors to our society. Equally important, we are investing heavily into mental health programs that are supporting Albertans on the daily. We've partnered with organizations like CASA Mental Health, our second largest provider of mental health services after AHS. With funding from this budget, CASA Mental Health is putting in place more mental health supports in schools across the province. CASA is bringing mental health professionals directly into schools, giving students the full-time support they need without interrupting their ability to receive an education. Also, in partnership with CASA, we are building more facilities to provide live-in treatment and day programs for youth with complex mental health needs. In partnership with the Calgary Counseling Centre and Counseling Alberta, we are providing same-day access to counseling services anywhere across our province, which is especially beneficial to those who come from remote parts of the province, such as myself. These programs could not possibly operate without commitment to mental health, and I believe this budget makes that abundantly clear to Albertans. Budget 24 includes $31 million for prevention and intervention, which means giving Albertans faster access to services in their community that help address challenges early from someone who might be struggling with mental health crisis. Included in this would be $4.9 million for ongoing operations of 211 Alberta to connect thousands of Albertans calling or texting every single month directly with services in their community. More than $5.5 million is supporting our ongoing partnership with police services in both Edmonton and Calgary to partner officers through help and PAC teams with mental health professionals on the street. When someone is in mental distress, police are often the first on the scene, but not many have the experience or expertise needed to safely and properly de-escalate a crisis situation. Funding for these outreach teams in partnership with our law enforcement is connecting people with the services they need and giving police the tools they need to keep our communities safe. These investments are more than just line items in a budget. They are making a difference in the lives of thousands of people every single day, and I've seen this firsthand as I visited treatment centers and spoke directly to Albertans across the province. Each time I visit a treatment center, I talk to them about the stories, and I ask them what hope they have in their life for treatment and afterwards, and where they'd be without the treatment. Many individuals have been homeless, trying to survive, but stuck in addiction with what seemed to be no path out. Many told me about how they want to reconnect with their children, with their family, how they want to be brothers and mothers and family members and community members again. Something that they're learning to do through our recovery communities and in recovery. And when I ask where they think they would be if they did not get into the zero barrier treatment facility that we have provided without missing a single beat, they raise their head and they tell me they don't believe they'd be alive today. The truth is that addiction can only end in one of two ways. It can end tragically in pain, misery, and run its course eventually in death. Or it can end in treatment, in recovery, and a hopeful new lease on life. This budget and our entire Alberta model of care focuses on recovery, because we know that given enough time, the other option leads down a path we dare not consider. Always chasing another high, always seeking a more powerful drug to satisfy the addiction. I believe that as we follow expert advice, as we follow what I believe is the moral path forward for our society, with policies based on evidence, we will continue setting an example, not just in Alberta, for our family members and our communities, and not just across our province not just across our country between other provinces, but on a worldwide, the example of what a compassionate solution looks like dealing with the crisis of addiction. And with that, I look forward to our questions today, and hopefully we can have a good time having a conversation around mental health and addiction and the wonderful opportunities that we're providing for those who need our services. Thank you, Chair.
Thank you, Minister. We'll now begin the question and answer portion of the meeting. For the first 60 minutes, members of the official opposition and the Minister may speak. Honourable members, you'll be able to see the timer for the speaking block in the committee room, and if anyone happens to join online later, on Microsoft Teams. Member, would you like to combine your time with the Minister?
Combined, please.
Combined. And Minister, what's your preference?
I'll ask for block time, please.
We'll go with block time then. Member, please proceed. The block time of share is 20 minutes, during which time, well, if you decide to go back and forth later on, you can, but for now it's set for 10. Go ahead.
Thank you, Madam Chair, and I'm very pleased to be here to ask questions of the Minister in regards to this very important file of mental health and addiction. I'll start off of, frankly, where the Minister landed, Madam Chair, around recovery communities. Per page 106 in the fiscal plan, in the capital plan section, $328 million has been allocated to recovery communities. There is a total of roughly $500 million dedicated to building and operating 11 recovery communities, Madam Chair. The first to open was in Red Deer with a $4.8 million annual operating budget, but we know, per the granting guidelines soliciting application for operating agreements, that the ministry would set aside $13.5 million per year for 3 years to operate the first 3 recovery communities. Red Deer opened in September 2022. Lethbridge opened September 2023. Gunn was included in that initial funding call, but is many months overdue, and the doors have yet to open there. And further, a recovery community was promised to the Blood Reserve nearly 4 years ago, and they have yet to put a shovel in the ground. Through the chair to the minister, each of these facilities is meant to have 75 beds. How many unique individuals are actually meant to flow through these facilities in a given year? How long will the average client stay at one of these facilities? And how many beds in the current facilities are reserved for women? Further, how many beds in the current facilities are actually operational? Are they all at 100% capacity? An important thing to note here is that beds are not the same as spaces. Beds are beds. While spaces, well, those are the number of individuals who occupy that one bed over the course of a year. The government lauds itself in having funded 10,000 new treatment spaces, but I think it is very critical to note that 3/4 of them, 7,700 of those new 10,000 beds, are short-stay detox spaces. That is roughly, detox tends to be 7 to 14 days. Through the chair, can the minister tell us how much it costs per day to staff a bed? Is there a different cost to operating a detox bed versus a treatment bed versus a recovery bed? I would assume there is, given the intensity of support required in the first, compared to a much lighter touch after several months of abstinence in a recovery community. Madam Chair, in 2022, when the first applications were invited, the decision on successful applicants was made in record time. The RFP was public in July 2022, and the decision was communicated with those few lucky applicants not a month later, in August 2022. Red Deer was operational 2 months later, but the others have been quite a bit longer. People are dying, Madam Chair, at a rate that we have never seen, and the government's recovery-oriented system of care is meant to save them. But at the rate we're going, which is, by my calculation, 175-bed recovery community per year, these efforts will barely staunch the flow of death and loss and suffering. And so, through the chair to the minister, when will the next granting call take place to prepare for the next batch of recovery communities when they come online? What was the evaluation rubric for applications in 2022, and will the same rubric be applied in future calls? Will the minister predict an equally expedient timeline in the future? Further, with this incredible emphasis on quite costly, $500 million to open and run these recovery communities, where is the funding for outpatient programs? Because as the minister mentioned, Madam Chair, this is meant to be a zero barrier process, but I can think of a whole lot of barriers: work, childcare, rent, that would prevent somebody from being able to put all of that on hold for 40 or 60 days to access an inpatient program. Where has the minister considered how the place of outpatient programs? It's not to say, furthermore, it's not to say that inpatient rehabilitation programs like recovery communities didn't exist before the adoption of the Alberta recovery model. And so through the chair, is the minister funding brand new recoveries at the expense of existing treatment facilities, some of which have several decades of proven effectiveness and many of which support some of the most complex participants? I'll move on from the recovery conversation from the recovery community conversation, to page 107 of the business plan 2024-27 and performance metric 3.A, which is in regards to the recovery capital scores and the My Recovery Plan software application. I'm not entirely clear how the minister would like us to refer to that, so I welcome their thoughts. I have a lot of questions in regard to My Recovery Plan, or MRP as it's known for short. The key objective in the business plan, Madam Chair, states that MRP will be used to support evidence-based decision-making to gauge the success of programs for the individuals who are actually participating in the Alberta recovery model. People watching at home may not know that the My Recovery Plan app is a proprietary platform owned by a for-profit recovery and treatment service provider in BC. The government purchased rights to use MRP here in Alberta, but I have some very significant concerns around the speed with which MRP was adopted and the rigor with which the platform had been vetted for the protection of information and privacy that all Albertans, particularly those who are most vulnerable, should be very concerned about. And so, in regards to MRP and the Recovery Capital Index, we'll start first with organizational considerations. Is it mandatory for treatment facilities to use the MRP and RCI platform? Is it mandatory for their clients to use it? What happens when a client, Madam Chair, refuses to use the tool? Does it impact the overall score of that facility? And furthermore, will MRP be used by former AHS, soon to be MHA run programs and departments? Through the chair, can the minister share to what extent future granting decisions will be made in consideration of an organization's recovery capital score? Is it possible then that a facility might pick and choose who they accept based on their likelihood to have the greatest improvement in their RCI? Is it not furthermore fair to say that some people accessing treatment have lower complexity than others, and that some treatment centers are better equipped to support high complexity or concurrence than lower acuity clients? Recovery is not a linear process, Madam Chair. People fall down and they pick themselves back up again time and time and time again. Gamifying that process with a recovery capital index score and basing future funding decisions on that should be of grave concern to Albertans and to all of those people who are struggling in the recovery process. And so if every treatment facility or recovery community across the province is using the MRP, that could amount to thousands of people's data and private information being shared, stored, and analyzed. I have some questions around the privacy considerations. Through the chair, what privacy assurances exist and who holds the data from the thousands of Albertans and dozens of organizations that use the app? Does it reside with the proprietary owners of the platform in BC? Has there ever been a breach of people's private accounts and information? Where is data stored and who has access to it? Who has access to the app itself and to the organizational dashboards that will inform, again, ministerial decision-making? Do the owners of the app hold rights to access Albertans' information contained within MRP? Lastly, I'd like to ask a question about Target 3.A that specifies that an indication of a positive effect of ministry-supported services is an increase in recovery capital from the first day in treatment or admission to a recovery community to the last day in treatment or discharge. So just to be clear, what's my score going in? What's my score going out? Through the chair, the minister must know that the positive effect of a stay in a residential treatment is not measured by the change from admission to discharge, but in the days that follow discharge. What we need to measure is how well a person fares once they leave a facility, once they are back in their community, back with their family or friends, back to work, back to the stressors that will inevitably come. I would argue that the parameters, Madam Chair, of this performance indicator are not helpful in any way. Further, we are relying on an unproven evaluation tool holding people's lives, their right to privacy, and perhaps the future of long-standing organizations in the balance. I'd like to hear the minister's thoughts on this particular performance indicator, Madam Chair. A lot is being placed in MRP, both in terms of individuals' personal and private information that can be incredibly sensitive. Is it being made available to employers? How is the tool being used? Who has access to it? And how will it inform future decision-making when it comes to funding and future grants for organizations across the province? Thank you.
Thank you so much, Honourable Member. We'll now turn it over to the Minister for his response.
Thank you, Member Ermanco, for that set of questions. I'll do my best to answer them. I tried to take notes, and I know my team did as well, so we'll try and go through it. So we started off talking about the capital plan in the budget, that $328 million over a number of years for largely, though not exclusively, the recovery centers that we're producing. So I'll first want to give some lay of the land, and I'm going to ask my department to go into some detail in terms of what we see as next steps and how we're trying to move forward to make sure that we do deliver these. And I will first thank the member for what seems to be an agreement that recovery is the center of a solution to someone in addiction. And I think that is the centerpiece we have to agree on politically. Understanding that there is an urgency from all sides of the aisle, and it's beyond political debate, that if we don't give people recovery, we are not going to see people getting better. And I think recognizing that from the start is a huge win for us as a province, because we see other provinces that don't have that same agreement, that they seem to be going down a drug facilitation argument and pitting that against what is, to be honest, the only proven way to get someone out of addiction, other than the tragic end that we all want to avoid, and that's recovery. And so the average is 75 beds, though some facilities will have more. Gun is an example of that. That will have more. It'll be up to 100, I believe. You asked about sort of how those beds are allocated, and I think you're right to say that beds and spaces aren't the same. And it's important we make that distinction exactly as you pointed out, that in any given year for a detox facility, which we can't have be the bottle of the process of those 10,000 spaces we added, we needed to make sure that the first step into the door to recovery as detox isn't a barrier. And so having that mass expansion of detox spaces allowed you to have potentially, 30 to 50 individuals in one bed go through. So that's 30 to 50 spaces for one bed. Now, the facilities that we're building, these recovery centers, they are high quality. If you were to go look for a private option of the same quality, you're looking at $10,000 to $20,000 a month easily in order to get that, and this is zero cost. So we also don't have a fixed program date for it. People can go through, and the member's exactly right, that every recovery journey is going to be different. And you'll see people coming back again, even after leaving recovery and falling, but then getting back up onto it, trying to get into recovery again and live that clean and sober and recovered life. So sometimes there'll be a repeat coming back again. Of course, we accept that. That's part of it. We also understand that it can be up to a year. People can leave at different times as they see progress and they get the skills they need going through recovery in that treatment facility. So for example, a 100-bed facility might have an average stay of 6 months. It could be an average stay of 9 months. It could be an average stay of 3 months. We're going to get some of that information as we spend more time collecting that data. And I can let my department speak to the preliminary information. Red Deer and Lethbridge run at a very high capacity rate, the two that we have open. And I'm not sure if we have exact numbers, but the beds are in high demand. We try and keep them moving through very effectively and efficiently. So the purpose is to have those very sought after zero barrier treatment spaces always in continuous use. And so the divide between men and women is approximately 2/3 men, 1/3 women. But that's not a firm rule, and we have an example in Lethbridge where the not-for-profit of Calgary that's running that also had a previous facility right next door that they have now transitioned to be run effectively in conjunction, but that one is committed to women in treatment, whereas the full facility of 75 bed is men in Lethbridge. Whereas Red Deer, it's a 2/3, 1/3 with separate wings. So it can change based on the particular design to meet the needs. And so maybe I'll pause right there and ask my department to give some more updates and details in terms of moving forward. Obviously, partnering with our Indigenous communities is very important. I'm hoping we have more discussion on that going forward. You mentioned the Blood Tribe. We're working very closely with them. This is not an imposition, but a proposition with our Indigenous partners. And so given that, we want to work with them. And that means making sure we're culturally sensitive in the programming, in the very physical design itself. And we think that putting that time forward now in that relationship is going to pay dividends for us as a partner with the Indigenous community. And so we're very happy with the relationship we have with Blood. And we are certain that because of that strong foundation, we are going to have better outcomes going forward. And then so I'll let my department touch base on some of those details as well, along with the cost per day on detox versus treatment as well.
Perfect. Thank you, Minister. I'll maybe start there with the costs for different bed rates. So at the highest end, and of course most intense treatment supports that are required and medical supports, detox is $300 a day. And again, it is, as was noted, a shorter stay, but again, really trying to shift the supports and to be quite individualized, and very importantly, the pathways out of that, which generally goes into the next step down, which is into a treatment space. That's $150 a day. And again, that can be for an extended length of stay in a whole variety of treatment providers across the province. And then the next stage is through residential recovery, which is $80 a day. To the question that was asked, Chair, about Red Deer, there have been roughly 150 individuals who have completed through the program over the first year. Of course, it did start up and wanted to make sure programs were well in place, but it is running at capacity or consistently very near capacity on an ongoing basis now, and certainly Lethbridge similarly is ramping up to being at full capacity. As the Minister mentioned, the ratios are intended to be roughly 1/3 women to 2/3 men, and continuously evaluating that, but it looks like a ratio that seems to be working for the time being.
That's fine. I'll just add as well, because it's important to note that number of folks that have been through Red Deer, it was a staged opening. Largely when it goes through commissioning, it's a class-based progression, and folks will go almost as a cohort through this, and they'll have other individuals that have entered at approximately the same time as a part of their cohort. So we didn't just open it up all at once for a full 75-bed occupancy immediately. With advice from the provider and what we know around recovery, we first started with a smaller class. I can't remember the exact number, but think of a dozen or 2 dozen perhaps. And then we introduced more as time went on, and they progressed through. So it scaled up in that sense. Thank you, Chair. And so I want to now address the MRP, which is my recovery plan. And so I appreciate the questions. It is an incredibly important piece of it. We are looking for evidence-based policymaking. We need to be collecting data. And right now, a lot of the data we have in the system are EMS calls and tragic overdoses, and that's important data to be collecting, for sure, something we need to be focusing on as an outcome, where we want to see how we're improving the lives of Albertans, how are we making this positive difference around the recovery model. But those are all latent indicators around data. We need to be understanding this earlier in the process. So what recovery capital is, and I'm very glad the member focused on that. Recovery capital is a sense of, are you getting better over time? Are you working towards those goals and plans you have to be in recovery, which isn't just to say abstinence, which isn't just to say sobriety and not using. I had a very experienced individual, he's in recovery for about 40 years, that I met this last summer, who told me for him being in recovery is being a grandfather. For him being in recovery is the ability to be a family member again to everyone that he wasn't for so many years of his life. He's homeless, opioid addict on the streets of Vancouver. And so the idea of recovery is something any government wants to see from a citizen. It means a fully formed citizen. It means a fulfilled life. It means a sense of gift to others and the ability to love and contribute back to the community and the society you come from. And so the recovery capital index is this idea of, are you working towards those end recovery goals? And for important clarification, it's an evidence-based metric, and it's also, when we look at the software we're using, and I'm going to have my team speak more to the rigorous work that has gone into privacy impact assessments, making sure we're following all the privacy legislation that's relevant, which is very onerous and is very important, so I appreciate the question. I'm happy to have them speak to it. But it's a not-for-profit organization that currently has it, that works in recovery, that we think is a great partner for us, because they also see that we need not just those latent indicators, but those earlier ones, and a sense of, are we progressing? So I know we didn't get through all of your questions. I'm going to probably ask my team to follow up with some of those in our next block. I'm very happy to. And I think so far the questions have been very, very relevant to the work that we're doing on the recovery model. So, Chair, back to you.
Thank you so much, Minister. And if you and your team would kindly direct the conversation directly through me, that would be much appreciated. We'll move over to the other side for their questions. Over here, yes, go ahead.
Thanks. Thank you, Madam Chair. If I may request, could I please, of the Minister and his team, the answers further applying to the MRP be provided in writing? I do have a number of other questions to get to, so I want to make sure that we do give some of those some consideration. My questions around recovery communities is not an endorsement of recovery communities. We are here precisely because we go through budget estimates specifically to avoid making assumptions. And so to the Minister, I appreciate that the recovery model is of course an important and real cornerstone program for this government. My concern is that the recovery model is at the exclusion of a whole other host of very important interventions that we need to be talking about. And so let's try not to make assumptions. That's exactly what we're here, is to ask clarifying questions and actually get to the heart of what it is that we're doing to support some of our most very vulnerable citizens. The next batch of questions I'd like to ask is around prevention and early intervention, Madam Chair. Speaking of which, on page 103 of the business plan, we talk about the Alberta recovery community model is based on this Alberta recovery model, is focused on keeping communities safe while treating mental health and addiction as healthcare issues by working with health and community service providers to deliver services that span prevention, intervention, treatment, and recovery. And I'd like to focus on the first two stages listed in that comment right off the top. Through the chair to the minister. Prevention and intervention. It currently receives a quarter of the funding that treatment and recovery is allocated in budget 2024, and received a nominal increase of roughly $500,000 from last year to this. Through the chair, can the minister explain to us what they include in prevention and early intervention in that particular line item of the capital plan, or of the estimates? There is real truth, Madam Chair, to the saying that an ounce of prevention is worth a pound of cure. Recovery communities and the wonderful CASA services provide to youth are important, but they are ultimately reactive. How is this government going to address the wait list to access AHS-funded counseling services? Because indeed, counseling, therapy, well-funded, easily accessible counseling services are absolutely fundamental when it comes to prevention and early intervention to avoid significant mental illness and perhaps that downward spiral that can lead to both chaotic and entrenched drug use. And so, as I mentioned, how is this government approaching AHS-funded counseling services that will very soon be within the minister's purview? How is the $5 million for Counseling Alberta going to possibly be enough to support Albertans when for many, many families, a deeply subsidized fee model is the only way they can access therapy? Non-group coverage, Madam Speaker, for clinical psychological services are up to $60 per visit. This is non-group coverage, up to a maximum of $300 per family each benefit year. Yet the Psychologists Association of Alberta recommends a fee of $220 for 1 hour session. That $60 that Albertans currently cover is wholly insufficient and does not remove barriers to service. And so, Madam Chair, what is the government's plan to bring the rate covered in the non-group coverage plan up to a reasonable level so that people can actually consider that during this affordability crisis? It leads me to a question that I have raised before with the minister. I know that there has been a recent development on this front and that the College of Alberta Psychologists has been proposed as the regulating body for counseling therapists. Objective 1.5 of the business plan highlights the need to enhance quality standards and legislative requirements guiding regulatory oversight and enforcement. Why has it taken 5 years to regulate counseling therapists in this province? And with the sudden cap announcement, will the minister share how the initial concerns, the initial reasons and rationale for why the delay was so prolonged, which is largely around consultation with First Nations groups, Madam Chair? What is it about this new arrangement that suddenly has resolved all of those concerns that were at the heart of what they claimed to be was the initial delay? There are 4,000 plus counseling therapists who are looking to be regulated bring legitimacy to their profession. But as a result of these delays, as a result of not forming a college, we have compromised public safety. We have compromised value for those dollars that are actually being given to counseling therapists. And I would like to hear further about how this recent announcement with CAP has actually resolved some of those concerns and what the new timeline will be to actually form a college. Furthermore, on that particular note, Madam Chair, all public releases from interested parties reference regulation of counseling therapists only. It doesn't include addictions counselors, Madam Chair. And so as we're talking about access to service, and certainly this heavy emphasis on addictions and treatment, why wouldn't addictions counselors be included in this regulatory environment? Why wouldn't this be a top priority for this government when we have an example, for example, up in Grand Prairie of a person who is hanging their hat and calling themselves an addictions counselors after a proven record of having assaulted patients in a former capacity. Without a college, there is nothing to say that there is no oversight over how she proceeds in her practice. Furthermore, in the latter half of this block that we have here, Madam Chair, it's interesting to me that the minister mentioned that recovery communities are zero barrier. I'd like to ask right off the top, are they also zero tolerance? If a person does have those occasional relapses, do they have to leave the recovery community? How long do they have to wait before they are allowed to be readmitted? This raises some significant questions around equity in the recovery model, Madam Speaker. Per outcome 2 of the business plan, Alberta's communities and families have the capacity to support individuals pursuing recovery. $229.2 million have been allocated to expand access to high-quality mental health and care. Through the chair, can the minister tell us how the ministry is focusing specifically on services for women, not just co-ed facilities, but specifically for women? Will they be creating, how will they accommodate women with young children or perinatal women who are about to give birth or who have just given birth? This, Madam Chair, is where we can talk about prevention and intervention. This is where we provide restorative care and where we can break the cycle of trauma. Furthermore, on the topic of equity, has the minister considered inpatient or outpatient programming specifically for members of the 2S LGBTQIA+ community? What is the minister doing to ensure safety for this group of people who deserve to access recovery service free of judgment, stigma, or hatred? Regions outside of Calgary and Edmonton are suffering under the weight of mental health and substance abuse in their communities, but there is a dangerous lack of service and supports. How is the GOA specifically addressing communities outside our 2 major cities? Further, where are the considerations in the business plan to provide mental health and addiction supports for racialized communities, Madam Speaker? Many of which are predominantly first or second generation, where there is often pre-arrival trauma, PTSD, undiagnosed mental illness, and hidden addiction. Why is there no mention of culturally appropriate funding, service delivery, or programming aside from Indigenous communities? To be clear, that is an incredibly important and terribly underserved community. There is good attention paid to First Nations, Métis, and Inuit communities in this budget 2024, and for that, I'm thankful. But to what end? In 2020, Blood Reserve was told they'd have a recovery community. Madam Chair, they have yet to break ground. What specifically to the minister is the delay? And through the chair and to the minister, multiple First Nations have declared a state of emergency due to drug-related deaths. All of Treaty 6, Athabasca Tribal Council, Piikani in my home territory of Treaty 7, and Athabasca Chippewan First Nation. What exactly does that entail by way of an escalation and response from the provincial government, and how will the province step up to that call? Lastly, how did the government select the First Nation communities that would receive one of the 11 recovery communities? I believe there are 3, perhaps 4 First Nations communities that have been assured that they would have a recovery community on site, on reserve. But as far as I know, and I welcome the minister to correct me on this, Madam Chair, it is none of those. Not Treaty 6, not Athabasca Tribal Council, Piikani, or the Chippewan First Nation that have all declared an emergency but have no recovery community on the horizon for them. And so to what degree did the minister ensure that there was equity and transparency in that selection process? And furthermore, what is, once again, the timeline? When can people expect for shovels to be put in the ground for the kind of planning and consultation and rigor that each of these communities independently deserve to ensure that there is a recovery community that is meeting their specific needs? And again, this is one of the big harms with recovery communities, is that even though we're talking about 11 across the province, where is the outpatient programming that would be accessible to all corners and all communities of Alberta?
Thank you so much to the Minister for his response.
Okay, well, thank you, Chair, for the opportunity. I want to start by going to talk a little bit more about MRP, just following up that outstanding information for you right now, right here. So I'm going to ask my Deputy Minister, because we got to the point where we're going to talk about the very onerous work being done with the department around privacy concerns. So I'll turn it over to the department to start there.
Sure, thank you, Chair. To answer a couple of the many questions that were asked, I think sequentially, so MRP is absolutely a critical tool to let data inform wait lists, to measure outcomes instead of just the number of people who go through the turnstile and are accessing. And absolutely there is follow-up capacity with recovery coaches and other service providers once people are leaving the facilities, including alumni programs that start up. So the aftercare is a critically important piece as part of that service. The Government of Alberta will not be using information through MRP directly or in an identifiable way. It is in aggregate form only to better understand, to support and improve the services for Albertans, and really importantly, ensuring tax dollars are being targeted to the interventions that are really working to save people's lives. So yes, it is helping to inform effectiveness and outcomes. It is not a mandatory barrier for individuals. If they're not willing, they will not be turned away. However, it is something that's being required with operators, and gradually, and making sure practices are in place so that they are using My Recovery Plan, because it deals with wait lists. It helps us measure program capacity, the types of outcomes that we're seeing. Over 1,400 people have already used My Recovery Plan, and we are seeing, as is outlined in the business plan, as was noted, the targets and the types of outcomes from the positive benefits for MRP overall. I think that answers a number of the questions that were asked, Minister, on MRP.
Thank you, Deputy Minister. Understandably and rightfully, Chair, questions were asked surrounding prevention and early intervention. It's a big part of our model moving forward, understanding that it is one of the most difficult things in a mental health and addiction space to get right. Every jurisdiction in the world sees that as the policy holy grail, for good reason. Is so much pain and misery is averted when we can get and reach individuals who are on that precipice of a crisis or going down the road of a serious addiction. Instead, we find and connect them with the resources needed. So some of the work we're doing here, $30 million has been allocated in this budget for initiatives that support appropriate crisis intervention and offer recovery supports where and when needed. The increase in this budget provides funding for initiatives that address the addiction crisis, police supports, enhance access to provincial helplines, and the City of Edmonton and City of Calgary initiatives, which I mentioned some of them in my opening statement. That's why we're doing the $30 million in early intervention services this year, including $2.5 for recovery coaches who support individuals in the pursuit of recovery, and $10 million in support initiatives to address the opioid crisis. That's 1.8 in Calgary and 3.7 in Edmonton. 4.9 million is budgeted support all 211 capacity assist in Alberta for all ages, access to critical addiction and mental health support services in the communities and connection. And then in addition, 5.1 million is allocated for the mental health call line and gender-based violence crisis hotline. I'm happy to have more conversations surrounding prevention, because I think it's an important pillar for us moving forward. When we talk a little bit about counseling, I'll just note that the non-group coverage is a question for Minister LaGrange in detail, not something directly within my portfolio. But Counseling Alberta is a terrific resource, Chair, that every Albertan has access to. And it's important to note that Counseling Alberta, when you call 211 or you go to Counseling Alberta directly, it's of zero cost if if that's what you request. It's a sliding scale for access to those services. So if you're in a position where you can afford more and you're willing to go down that road, then you're very welcome to that. But the access is meant to reduce barrier as well. Understanding we should be responsible for people who can and are willing and interested in trying to support through payment around that. So this is going to speak to some of the questions for access to rural Albertans as well, which I know you asked later on, and I'm happy to go more into those details at the time. But it's $4 million in-year funds on a per-year basis to that end. And so you did also, through the chair, I think there were a few questions around zero barrier and if there's some connection to zero tolerance. I don't know if there's a misunderstanding. So maybe I'll just clarify the nature of the recovery model for folks who are following along at home to understand what we expect in terms of how this is supposed to work. So we want to reduce the barriers. For example, there's a $1,240 barrier that the previous government under the NDP had left in for those suffering from addiction, and to get access to that monthly treatment, you had to find over $1,000 a month. Not particularly easy for those who are living in addiction to find those dollars. You can imagine where that often came from. This is meant to be universal health care coverage, and we believe it is life-saving health care. So, of course, we're going to reduce that. And there will always be difficulties in any individual's life who's suffering from addiction, of course. When I say zero barrier, I'm not saying that life is made easy for everyone all the time. I understand the struggles they go through. When I say barrier, I'm saying on the government side, why would we throw up barriers we don't need to? And that is the policy. And I'll tell you, in recovery communities, it's largely self-enforced when it comes to this idea of being in recovery and abstaining from the use of the drugs. I could tell you my interaction with folks when I've been to Red Deer and Lethbridge and other outside of the ones that we've created. It's going to be tough to try and hide from other users if you're using. They will know, and they are a community. That word community is key. It's self-enforced and self-policed. If somebody does fall and end up back into addiction and using again, then it's a community itself that says that this isn't the right place. But it needs to be abundantly clear. This government's meeting Albertans where they're at. If they're in active addiction, or if they're in recovery, or they're in transition, or they're in detox, if they're young, if they're old, no matter what their background is, to those questions that we heard later on, which I'm happy to get to around minority groups across the province, it does not matter. We want to meet you there and help you on an off-ramp off of addiction. And there are numerous Albertans that have been through recovery communities multiple times. And I believe you made that Chair, that members made that comment early on, that they recognize that this will be a repetitive process for some people. That's not prohibitive by any means. We are about recovery. And any individual wants recovery. Any political party wants recovery. Any provider wants to provide recovery. Then we are partners with you. That is my coalition, and it goes right down to the very individual soliciting their services all the way to AHS and the biggest partners across the country when it comes to treatment. So I hope that helps you understand the culture of what we're doing. Now, when it comes to particularly supporting women more broadly than that allocation of 2/3, 1/3, which we set that allocation up broadly based on the data we understood to be the rate of addiction amongst men and women. But we also know that especially vulnerable women with young children are a good example of this, that they need to have specialized care. So we have also funded beds to that end and spaces across the province to that end, something that I want to continue to scale up. It's particularly close to my heart as I see the very difficult challenges these young mothers have and all the capacity they have if they go through recovery of being terrific family members and mothers and citizens and individuals of our community again. So I'll let my department address some of the work we're doing around supporting women in addiction with children and families.
Great. Thank you, Minister and Chair. A couple of the programs that we could point to for women and children as well as racialized communities, I know is part of the question as well. Alberta's government is providing more than $4.5 million in funding over 3 years, for example, for immigrant and cultural serving organizations, really providing some of the specialized mental health and addiction services and very much specifically targeted for children, youth, and families. For example, the multicultural health brokers in Edmonton providing prevention programming and supports to immigrant and refugee children and youth in over 16 ethno-cultural communities. As well, Albertans who are more comfortable accessing help in their own language can access and receive support from translators in more than 100 different languages through 211, and connections to mental health lines as well, offering supports.
I think that's helpful, and I just want to make sure I address a few other items. The question surrounding regulation of counselors and counseling therapists, incredibly important space. Obviously, we're going to be continuing to do that. The particular questions asked are not relevant within the budget documents, as far as I understand. If you can point to a line item, I'm happy to address that spending. When it comes to Indigenous communities, and unfortunately, the member said through the chair, the harms with recovery communities that we don't track them going forward. Well, that's not a harm of recovery community. The recovery community is doing great work, and we do plan on tracking
Thank you so
them.
much, Minister. We'll have to come back to you for more answers, but at this moment, we'll turn to the government side. Please proceed, member. Oh, wait, you've got, no, sorry, I'm getting ahead of myself. All I can think about is my bed, so please, members, go ahead.
That's okay. That's okay. That's okay. Thank you. Okay, I will move on. Thank you, Madam Chair, to the Minister for the answers to some of my questions here. I'd like to address Performance Indicator 1.B, really just kind of a clarification in terms. You mentioned, the Minister, Madam Chair, mentions the current focus of this indicator is on 4 client groups receiving new or expanded services, involvement in one or more of these client groups, and an increase in program involvement over time is indicative of a positive, wider system impact. This has to do with the percentage of Albertans receiving care at an appropriate level. Madam Chair, through the Minister, what are the 4 client groups? Just a pretty straightforward question rather, that I hope we can get answered this evening. Moving on to page 105 in the business plan, key objective 1.2 aims to ensure every Albertan has access to high quality recovery oriented care to improve their overall well-being and help sustain recovery, while key objective 3.4 aims to support initiatives to decrease the number of opioid-related overdoses in the province. Madam Chair, as many in Alberta know, we have experienced the deadliest year on record for fatal drug poisonings. From January 1st to November 30th, Alberta lost 1,700.
A point of order has been called. Go ahead, member.
Thank you, Madam Chair. The point of order is under Standing Order 23B. The member speaks to matters other than the question under discussion. And Madam Chair, the committee is convened for the purpose of considering the Ministry's 2024 budget, including estimates, fiscal plan, and business plan. And the matter that has been raised by the member is not within the boundaries of the said topics. The matter that was mentioned by the member regarding the opioid crisis is outside of the topic at the hand of the committee today, Madam Chair. They are making it a point of order under Standing Order 23B, warranting the member to be called to order. Thank you, Madam Chair.
Thank you, member. Opposition?
Thank you very much, Madam Chair. I do not believe that this is a point of order. The member clearly referenced key objective and was speaking directly out of the business plan where it mentions opioid overdose. And so I think this is absolutely within the realm of the discussion, and I would argue that this is not a point of order as it directly relates to the words pulled right out of the business plan.
All right, members, so what I'll say about this is when it comes to the minister's time to address the group, if he chooses to answer it, then we'll defer to him. So at this moment, please proceed.
Thank you. It has been 5 years under the UCP's drug policies, and we have the second highest death rate in the country. The minister often compares Alberta to BC, as he did in his opening comments, who have taken a decidedly different approach. Indeed, their death rate per 100,000 is higher, but there is an important consideration here. Their death rate from 2022 to 2023 increased by 7%. Over the same time period, Alberta's death rate increased by 24%. If that rate continues, we will sadly surpass BC. Through the chair, what does the minister have to say about Alberta's growing number of deaths and the steep increase in the rate of death from 2022? To be clear, one of the objectives stated in the business plan is to support initiatives to decrease the number of opioid-related overdoses in the province. At what rate at what time rather, will the government pause and ask itself if the Alberta recovery model is adequate? There's no doubt that there are more funds flowing to mental health and addiction than ever before, but to what evidence can the minister refer that demonstrates value for that spend? Namely, does the minister believe that the Alberta recovery model follows best practice, data, and expertise in their investments in order to reduce harm and to stop people from dying? Per page 165 in the general estimates, line 2.6 in the operating expenses labeled initiatives that reduce harm. In the description of supply, Madam Chair, this is defined as funding to support supervised consumption sites, overdose prevention sites, and the provincial naloxone program. Evidence shows that harm reduction is what saves lives and provides the opportunity for health-seeking behavior that moves a person toward recovery. The budget has gone up by $5 million, Madam Speaker, this year in comparison to the fiscal year prior. We know that $5 million did not go to renewing a funding agreement for an Alberta-based mobile drug testing pilot initiative. And I have learned that the government has even constrained access to basic drug testing strips. Perhaps the additional $5 million will be used to make nasal naloxone kits free, since people surveyed report they are more inclined to administer in nasal form than by injection, but they currently cost $120 to purchase at a pharmacy. What portion of line item 2.6 in the estimates is allocated to the operation of overdose prevention sites and supervised consumption sites? Through the chair to the minister, these services will be squarely within the purview of the minister following the transfer from AHS. Through the chair, does the minister intend to close the overdose prevention site in Red Deer in line with the recent vote by Red Deer City Council? And through the chair, can the minister commit to keeping all current OPS and SCS open, the ones that are AHS operated, with adequate operational funding, knowing that we are in the throes of a significant overdose drug poisoning crisis? Excuse me, I've lost my other batch of questions.
Take your time.
Thank you.
We've got a lot of it.
Thank you. I'll move on to compassionate intervention. Per page 114 in the fiscal plan 2024-27, this is in the capital plan section, there is a line item for compassionate intervention implementation intake and assessment centers with $5 million allocated in this fiscal year, plus another $5 million in 2025-26. Furthermore, per page 105 in the business plan 24-27, key objective 1.3 is to develop strategic approaches, including a compassionate intervention framework, to expand access to timely and appropriate mental health and addiction services across the province to support individuals who are a danger to themselves or others. This capital plan allocation of $10 million over 2 years to build a compassionate intervention implementation intake and assessment center is not congruent with the other budget 2024 documents, which briefly touch on the framework. The budget 2024 is really quite lean when it comes to discussing what either of these investments are actually going to entail, Madam Speaker. As you can imagine, there are many reasons why Albertans should be deeply concerned about involuntary or mandated treatment for people who use drugs or who are addicted. The Premier and the Minister have mused frequently about forcing people into treatment when, for lack of other reasonable solutions. And so you can imagine that a capital allocation of $10 million certainly raises the eyebrows of many people who know about the history that lead up to this conversation. And so to the chair, through the chair, to the minister, your government has been musing about mandated or involuntary treatment for several years now. What is this capital allocation? What is the $10 million allocation before a framework has even been established, before any legislation or policy or regulation has been introduced? Though they are imperfect, there is PCHAD for minors who can be forced into treatment for 14 days, give or take. There is the Mental Health Act that does include chaotic drug use and addiction when that drug use poses an imminent risk to the person or to others. There are restorative justice practices and drug treatment courts that can mandate treatment. There are employers in child and family services who ostensibly mandate treatment and or sobriety to maintain employment or custody/visitation. What is it, Madam Chair, to the Minister?
Motion, it's fine.
What is it about our current legislation, the current host of programs that I've just referenced, the current policies and regulations that are inadequate to this minister?
Point of order has been called. Please proceed, member.
Thank you, Madam Chair. The point of order is under Standing Order 23B. The member speaks to matters other than the question under discussion. Madam Chair, the committee is convened for the purpose of considering the ministry's 24 budget, including estimates, fiscal plan, business plan. The matter that has been raised by the member is not within the boundaries. We are not here to talk about the policies of any ministry here. We are here to talk about the budget 2024 estimates. Thank you, Madam Chair.
Thank you, honorable member. Opposition?
Thank you, Madam Chair. I wish the member would listen along because the member was very clear talking about per page 105, the business plan 2024-27, develop strategic approaches, including a compassion intervention framework. So she's asking for clarity on that. I think it is well within the bounds of this estimates, and I do not think that it's a point of order. Thank you.
All right, thank you so much, honorable member. And for this item, again, I will say if the minister chooses to address it when he gives his remarks, we'll leave that there as well. So please proceed, member.
Thank you. So as I mentioned, I'm curious about what both of these items in Budget 2024 are addressing that our current framework doesn't already, Madam Chair. Furthermore, can the minister discuss what a compassionate intervention framework and the capital bricks and mortar considerations are around the capital plan to build intake and assessment centers, what those are providing and whether they are filling a particular gap, and if so, what is that gap? Does it rely, I'm curious, a conversation that arose previously that certainly is within the business plan for mental health and addiction is around therapeutic living units. Does the compassionate intervention framework rely heavily on therapeutic living units in remand and corrections for implementation and operation? I would expect that if we are going to force a person into treatment against their will, that there would need to be a certain amount of confinement or restricted mobility involved. And my last question in regards to compassionate intervention is that if the recovery communities, Madam Chair, are the panacea that this government is positioning them to be, with the same day admission that people need them to provide, won't people be eager to voluntarily access detox, treatment, and then recovery in one of the government's new Alberta recovery model branded recovery communities? Won't they be eager to voluntarily access these programs rather than being forced into treatment? If they were everything that they were meant to be, we would not be looking at forced treatment. If we were everything that they were meant to be and truly zero barrier, then people would be, I would expect, eager and pleased to be able to access the services and programs that are offered within its walls.
Thank you so much, honorable member. We'll move over to the minister for his response.
Okay, well, thank you for the set of questions. Give me one moment here. So, first off, I want to start off by addressing a question that was asked previously surrounding how we choose which communities we put on reserve the four recovery communities that we're building in partnership with Indigenous First Nation communities. So, it first needs to be highlighted that the fact that we're doing this is noteworthy in an important sense, and I'd be a bit grand here in a constitutional sense. The federal government has a responsibility on First Nation reserves, and they have absolutely abandoned them, Chair. It is so tragic to see First Nation chiefs right down to individuals that I meet in my constituency, which I represent a very wide group of First Nations and Métis, or across the province. and see them saying, please, can we have access to recovery? The government that is responsible for helping us in this very difficult state has abandoned us. They're funding $100 million a year for SUEP grants that go towards so-called safe supply. And they just look over the destitute that you see on these First Nation communities. If you talk to Chief Crowfoot, for example, in Siksika, and you see what the tragedy they're going through, and they have choice words for a federal government that has, in their mind, obfuscated their responsibility, and the provincial government has stepped up. So I'm going to let the department talk a bit about the details and how those particular sites were chosen, because I think that's relevant. And the member chair is very right in that First Nations are disproportionately affected by addiction in our province. So we have to step into where the federal government has abandoned its fiduciary responsibility to its First Nations and the province of Alberta.
Thank you, Minister. Chair, in response to the question specifically with Blood Tribe, yes, it absolutely has taken a bit of time to work in a very different and unique model on reserve in a space where provincial governments don't just go in and build facilities. We're pleased that there are contracts that are in place. The planning is underway. It took a model from a previous recovery community and really worked with the broader community. Again, Blood Tribe is the largest First Nation in the country, and working with the uniqueness of the community needs to establish what that design looks like. And construction is awaiting this season to hastily proceed, but it really was a new process. With the other four recovery communities, they're at varying stages of readiness. They are grants to the First Nation communities to be able to build on reserve in an expedited way, and those are some of the learnings from our earliest work with the Blood Tribe. And shovels will be going into the ground this summer, we know, with those communities. They are based on selection, the size of community, absolutely, starting with Blood Tribe, where we have gaps in any other services, like in Southern Alberta. Feasibility to have more than 100 staff available to move and work and live in that community, which obviously in very small communities is more problematic, and absolute willingness and support from the communities to have them on reserve were all factors that went into those first selections of sites. Minister?
Thank you. And I'll go on now to address some of the questions you asked surrounding drug poisoning, so-called. And I want to, Chair, address language used surrounding recovery communities being the panacea to addiction. I think it is very important, Chair, that we look at what is the panacea to addiction. Addiction is a disease of loneliness. It's a disease of isolation. It is caused often as a result of trauma and an alienation that comes out of the difficulty of an individual living and not receiving the connection and community they need. The antidote, the panacea to addiction, is not more drugs. The antidote is not facilitating more drug use. And drug consumption sites on every corner will not solve this crisis. It, by definition, cannot solve this crisis. By definition, what solves a crisis of addiction is getting out of addiction. And that, by definition, is recovery. And I encourage all members opposite to be very serious and not flippant in their questions they ask surrounding the importance of recovery in this. And so I want to go in now and address some of these questions around Alberta's record. Alberta's record, I think, is one of terrific outcomes when you compare it to, say, British Columbia. As members of this committee have already admitted into the record, British Columbia has a higher rate, continues to have a higher rate, and all likelihood has no serious plan to try and reverse that in any serious way. If they put drug consumption sites on every corner in Vancouver, and they provided safe supply to every single possible user who's suffering from addiction, they would not see a solution. The only way out of it is recovery. And everything about a recovery model is trying to get people off. And so some of the successes that we've seen since 2016, pharmaceutical opioids have been reduced, deaths from pharmaceutical opioids have been reduced by 80%. Since 2021, deaths from methamphetamines have been reduced by 41%. Since 2021, deaths from cocaine have been reduced by 61%. Since 2020, deaths from alcohol have been reduced by 60%. And since 2017, deaths from benzodiazepine and different benzos have been reduced by 33%. Now, that is a start, but it is not enough. The truth is, we have to absolutely double down and focus on it. And so we will continue to, using evidence-based research, for example, the Stanford Lancet Commission, written by the world's furthest expert on the opioid addiction crisis, Dr. Keith Humphreys, who is the chair of the Recovery Advisory Panel that I inherited, who is a past advisor to Presidents Barack Obama and George Bush, and the current advisor in the White House to President Biden, is universally seen to be one of the best, if not the single best expert. We are following the evidence put out in his research, along with numerous of others internationally, on the path forward around recovery.
Thank you so much, Minister. We're going to take our 5-minute break now, everyone. Well, hello, everyone. That was a very nice break. Let's resume our session here. And we had concluded with the minister's remarks, and now we'll go over to the government side. Please proceed, member.
Thank you, Madam Chair. Through you to the minister here. Minister, we'll check your preferences. You want to go back and forth or you want to block time?
I'll guess I'll go block time, whichever works for you.
Thank you, Minister. And thank you, Minister, for supporting addiction response and recovery-oriented programs that will help Albertans access prevention, intervention, and treatment-focused healthcare. And I applaud your efforts and commitments to such initiatives. And my question is on therapeutic recovery committees. The delineation of outcome 2 within the ministry business plan highlights and aspects of Alberta's vision for supporting individuals in their journey towards recovery from various challenges, including addiction and mental health issues. The outcome underscores the crucial goal of empowering communities and business and families throughout Alberta to become active participants in fostering environment conducive to individual recovery. It says areas of focus include building and operationalizing new recovery communities. The emphasis on building and operationalizing new recovery communities signifies a proactive approach towards addressing the multi-phased needs of individuals seeking support by investing in the establishment of these specialized communities. Relating to that support by investing in the establishment of these specialized communities, can you please tell us about the current progress in building and operationalizing these recovery communities? And could you please elaborate on how these recovery communities will help support individuals pursue recovery, and recognizing that people in addiction require more than just to achieve full recovery? How will recovery communities impacting other areas of a person's life? And Minister, a significant initiative of this government's approach to a comprehensive mental health and addiction system are recovery communities. Recovery communities are a major addition to our province infrastructure and a key factor in transforming Alberta's healthcare system. I have had the opportunity to learn about these recovery communities and the innovative role they play in Alberta's recovery-oriented continuum of care. And I understand the Red Deer and Lethbridge communities have already opened to a positive reception, with 9 more on the way to be opened across the province. More especially, I see the partnerships with First Nations to build 4 recovery communities in Enoch, Sutina, Siksika, and Blood Tribe as an opportunity to make significant investment in these communities and ensure that they are high quality, land-based, and culturally appropriate services for Indigenous people. In the business plan, we see recovery communities as a key contributor to the success of outcome 2. Alberta's communities and families have the capacity to support individuals pursuing recovery. Page number 106, Ministry Business Plan. And Minister, could you provide us with an update on the 2 communities that have opened so far, and multiple other recovery communities are in development. Could you please provide us with a status update and timelines for these other communities? And I will focus my question on addiction and mental health system. And Minister, mental health and addiction are very important issues. This government recognizes this fact, and what we see in this year's budget documents reflect this position. Addiction and mental health truly require an entire system with a wraparound supports, and these are complex issues that are served poorly by a piecemeal approach. And to drill down on that point, that means that individuals suffering from mental health and addiction challenges are poorly served by a disjoint approach, as well as those around these individuals. And I'm happy to see this government is prioritizing a holistic approach to these very large challenges. And outcome 1 on page 105 of the business plan demonstrates this, with the goal of ensuring Alberta has a comprehensive, integrated, responsive, recovery-oriented addiction and mental health system. And this is supported by Objective 1.1, which is to develop a new mental health and addiction system as part of a refocused health system to better support Albertans experiencing mental health and addiction challenges. And Minister, as much as possible to summarize a very large reform, could you please provide a brief overview of your approach to building a new comprehensive mental health and addiction system? And why is now the right time to make this change here? And Minister, thank you. And with that, Madam Chair, I will cede my time to MLA Bouchard.
Please proceed, member.
Thank you, Madam Chair. Looking at the estimates for the Ministry of Mental Health and Addiction, I think I speak for the members on our side, hopefully from the opposition as well, when I say we're very impressed. Looking at line item 2.8, we see that 1.13 billion that was not part of the budget last year. The government announced significant changes to the healthcare system, including how services are delivered for mental health and addiction-related care. Now, given that this 1.13 billion is now being managed directly by the Minister of Mental Health and Addiction, I believe it reflects a commitment on putting an emphasis on the importance of these services, especially as it was previously a non-specified area of AHS that did not get the oversight or management from government that it deserved. With that in mind, I have a few questions around healthcare refocusing as it relates to mental health and addiction services. Why is this an important part of building the Alberta recovery model? How is the government bringing in more accountability to trace outcomes of mental health and addiction services currently provided by AHS? 1.13 billion is a massive investment. At a high level, how will this investment be used to help Albertans? And one more, big change is rarely without criticism. Minister, how would you respond to criticisms of this action to create a new mental health and addiction system, or allocating this kind of money to support this new direction? One more question on this, 1.13 billion infusion, still on page 105 of the business plan. It's clearly a major investment and one that I think well warrants our time today. With this type of major investment into the mental health system, it's important that we discuss how we're going to measure success, looking at both timelines and performance metrics. I'm bringing this up because my constituents ask me when these healthcare changes are going to be implemented and what they're going to look like for us. So I'm always keeping my constituents and their healthcare service delivery top of mind when looking at the end result of this type of investment. As with any government investment, it will be critical to continually evaluate and ensure these funds are, in fact, moving the needle in the right direction on government targets. And looking at pages 105 and 106 of the business plan, we see two performance measures. One performance measure is outlined with specific annual targets, which looks at mental health and addiction-related emergency department visits. However, the second performance metric is still under development. That's the percentage of Albertans receiving care at an appropriate level. Page 106 of the business plan indicates that baseline data will be collected on this performance indicator in 2024-25.
Much honorable member. We'll go to the minister for his response.
Thank you, Chair. Thank you, members, for your questions. So I'll do my best to answer the questions again. There are a number of them. I'm going to start by answering a previous question around the 4 client groups that are included in the funding asked by a previous member. So those would include supervised consumption services, virtual opioid dependency program, therapeutic living units, and residential addiction treatment. And also, I'll just address quickly the question around drug testing, and I'm happy to get into more detail on these questions afterwards. Drug testing and naloxone have been things that have been presented to us as possible policies. I'll let my deputy minister speak to some of the evidence-based information that has informed us and where we've arrived so far.
Sure. With respect to drug testing, Chair, some of the evidence I know that we've been following, including through the Canadian Centre on Substance Abuse, does point to drug testing not actually necessarily changing behaviors in drug use. And in fact, looking at fentanyl and others, individuals are still continuing to use after testing and are not being thrown away. So there's problematic behavior to suggest that that's a concerning place for investments, which has led to pause. Additionally, on the naloxone side, questions with nasal naloxone, it's 3 times the cost, and we did do a pilot project supporting that being implemented in Edmonton. 3 times the cost, and oftentimes reporting that it required an injection of naloxone afterwards. So the efficacy was a concern. So between cost efficacy and wanting to make sure that we've got the most kits available in the hands of Albertans, over $10 million a year going towards that, that's where continued attention has been focused on the intravenous side.
Okay, thank you. I'm going to continue on with some questions I received as well, Chair, if it's all right with you. So a lot of the questions I received are surrounding the recovery centers themselves. So as members will know, there are 11 recovery communities across the province that we're planning to build. We still have an announcement for one more Indigenous lead in that, but 4 of those are Indigenous, partnering directly with the First Nation communities, both in the capital piece, but also going forward operationally, making sure that we're with them. So stay tuned for more to go. That's $99 million in this year alone, just for the Indigenous-led pieces. This kind of investment is really unprecedented, and it's not a simple lip service. This is the closest thing to fulfillment of reconciliation that I have seen in my time in my ministry of mental health and addiction. I'm incredibly proud of it, and the kind of relationships that can be forged because of this kind of putting our money and our actions where our mouth is and looking to partner and walk with First Nations has just been an incredible experience. And that also has informed our approach around culturally sensitive and culturally appropriate treatment spaces. So much of that sense of making sure it's culturally appropriate comes from the fact that First Nation and Métis Albertans are disproportionately represented in the addiction crisis in rates that are just so hard to see when you look at the human cost of what that is. And so the treatment centers themselves are focused on how we can partner with them, taking evidence-based medicine and the proven path of treatment via recovery and marrying that thoughtfully with the lead of the First Nation itself. And that could be Blackfoot, that could be Cree, that could be any number of others across the province that we partner with. The question of really what is recovery came up as well, and I think that's an important piece. I touched on it early, but I can't overstate how recovery is not simply a question of abstinence. If you look at the nature of what addiction is, and what we're going through is an addiction crisis, the language here is incredibly important. We're not going through what some activists in the media or in certain spaces of the radical activist world say. It's not a toxic drug supply that causes the problems. I'll be honest, all the different supplies of drugs that people use recreationally that lead to addiction are toxic. All of them. It doesn't matter. And the idea that somehow there's just some that are toxic and others can be used safely as a lifestyle choice or something is beyond comprehension. When you talk to people going through recovery, you understand it's addiction that is the crisis that we're facing. And addiction is a disease of loneliness, of isolation, that leads often and tragically through trauma, and often tragically through intergenerational trauma that leads to more and more use. And so recovery is reparation of relationships. It's repairing and being in reconciliation in the most intimate possible sense with yourself and those around you so that you can have a balanced, fulfilled life again. And that's why I often talk about being a mother or a brother as examples is a good idea of what it is to be in recovery. Not simply in abstinence, not simply sober, but being a family member and a community member and a citizen of our beautiful country and province again. And so we did talk a little bit about the Red Deer facility as well. And so just Red Deer and Lethbridge both are open, 75 and 50 bed facilities. And the First Nation component is incredibly important with $99 million that are being invested in it this year. So some of the reason that we chose where we did is we looked at where there was a high need and a high population of First Nation and more broadly Indigenous that are struggling. And we look for willing partners who are talking to us and asking. And of course, the demand is always growing, and there's more and more requests all the time. I'm working to try and meet those needs as they come up. But I want to do what I can to make sure that we get these 11 facilities built as quickly as we can. Within the law that we have for infrastructure, which is a giant frustration at times. We have all sorts of checks and balances, appropriately so. But as members of this committee have mentioned, it's life and death for those who can't receive access. And that's why it's so absolutely important that we start doing this and we start doing it right away. We have limited resources in the budget. That's the whole purpose of our exercise here in estimates today, and the budget itself and the nature of our very parliamentary system is we have limited resources. How do we prioritize them? And this government has been emphatic that we're going to prioritize them with making sure that we have recovery centers built. Mental health and addiction was also brought up by a pair of members as well. So I want to address that in a broad sense. So if we look at 5 years ago, before the United Conservative government took office, there was no Minister of Mental Health and Addiction. There was no Associate Minister of Mental Health and Addiction. There may have been a director and an assistant deputy minister buried somewhere, but this government has taken a different approach. This government has said that this is a serious policy space, one that Albertans want to focus on. And we went to, first, an associate ministers. We saw the capacity grow within the department and the need for this, and the policy space build out around recovery. That's when we expanded. And thankfully, the Premier appointed just over a year ago a full minister to this. And the budget that I inherited in the previous budget, look up the operational budget in the previous year's document, it was $275 million, thereabouts. We're now at 1.55 billion, as member mentioned. And Chair, I can't tell you how absolutely important it is that Albertans see actions to believe what we're doing here. And I think that point is incredibly real. So you can see an increase of double digits, no matter how you want to slice this pie, when it comes to the Ministry of Mental Health and Addiction. That doesn't include the $1.33 billion that we're inheriting from previously AHS, and those services are going to go to augment and focus them on recovery in both the mental health space and an addiction space, because every single Albertan deserves the right to have access to recovery. One of the questions asked was surrounding criticisms and how I'll respond to criticisms as we go through this very big change, and I appreciate through the chair that is an important question. I appreciate that making important changes will have opponents, or at least those who fairly want to ask questions for review. That's the nature of a legislative body. That's the nature of an open and democratic society. But I'll challenge anyone to come to my community or bring me to their community and tell me that the system we inherited in 2019 was working, especially when it comes to mental health and addiction. I would challenge them to come to Manning, where I had a town hall around mental health and addiction in my constituency, and that community was rallied as they saw a tragic suicide in their community. And unfortunately, had we been doing this transformation earlier, we may have been able to prevent some of these tragedies from coming out and destroying communities and families. So the criticisms, of course, and the scrutiny is important, and I appreciate that question. But we aren't making decisions in a vacuum. We're making these decisions with real options in front of us. And it's not the grass is greener on the other side no matter what. All members need to realize.
Much, Minister. We'll move over to the official opposition for their questions.
Thank you, Madam Chair, and thank you for the opportunity to speak today. I would like to focus on child and youth inside this.
Is your request to go back and forth?
Oh, I'm sorry. Would you like to go back and forth?
I'll stick with block time. Thank you.
Okay. So, apologies. So block time then. Just starting off with the, so in the business plan, it states on page 103 that the department is accountable for responding to addiction or mental health related recommendations from the Office of the Child and Youth Advocate. So that will be predominantly what I am focused on, of course, relating it back to the budget. So the last annual report from the OCYA indicated that there were 33 mandatory reviews that they did on tragic young deaths of children who were in care between April 1st, 2022 and April 31st, 2023. 22 of these youth, so 67%, contained specific mentions of mental health concerns, substance use, or both. And at least 16 of the 33 youth who died was from drug toxicity, 49%. So young people are dying. And although this fiscal year is not yet done, we have one more month for the advocate to report the deaths from this month, and we do know there's been a handful of them. But we do know is that 2022-23 was the most deadly year on record with 50 deaths. And we continue to see that same trend. So,
Remember, we're here for main estimates. So if you would kindly ask your questions to the minister, we'll please get back on track.
perfect, because my next line was page 165 of the budget. Line 2.7 shows a cut of $22 million from what was forecast in the last budget. In addition to that, I also noticed there's a $26 million addition in capital grants. So through the chair, can the minister explain the decrease in funding for the frontline interventions? Can the minister provide insight into these grants? And through the chair again, can the minister explain how shifting resources from the ongoing frontline resources for these young Albertans is smart to move it over to, well, apparently it looks like capital. So further recommendations, and again, these all do connect to the budget in that these recommendations, as I read before, the business plan does state that they are accountable for responding to these recommendations. And so really a lot of my questions are asking for specific actions that the ministry has taken and where that funding is coming from inside this budget. So going on to another recommendation that has not yet been completed by the ministry. There was a recommendation, again, in reminding everyone that these are recommendations that come from tragic deaths of young people, right? So this is very serious, and so when these recommendations are made, it would be in all our best interests that they are actually applied. And in fact, earlier the minister had mentioned that we need data, we need something to substantiate what we're doing. This is data, and this is data that's been provided to this government since the advocate was first created, it was first moved out of the ministry. Anywho. So there was a recommendation back in June 2018. So I'm not kidding you, these things have been in there forever, where we are looking for health promotion and age-appropriate substance use education in junior high and high school curriculum. So my question is where is any of that activity happening in the budget? Which budget line would I find it under? And again, on the business plan states on page 107 under outcome 3, key objective 3.3, evaluate and expand access to mental health supports for youths in school and community to promote positive mental health, prevent severe mental health issues from developing, and provide treatment for students with mental illnesses. So through the chair to the minister, what do these supports look like specifically? Which budget line can I find the funding for these supports? Further, outcome 3, again in the business plan, page 107, indicates that Albertans have access to high-quality, person-centered mental health and addiction programs and services. And it specifies integrated school support programs as a priority for this government. So again, through the chair to the minister, should Albertans expect more professionals in school to offer these services and supports? Will there be, or is this another item that may not be addressed? And again, through the chair to the minister, if the minister is not able to answer these questions in the room, I would happily accept answers in writing, which might provide the minister the opportunity to connect with fellow ministers like education, for instance. Thank you.
All right, Minister, we'll move over to you for some answers.
Okay, thank you very much for that. Starting off, focusing around children and youth in the budget, I appreciate the prioritization of that, and I'm very happy to speak to it. So we have a number of different programming items that move forward where it comes to youth and family, particularly partnering with other ministries, but of course also within mental health and addiction. For example, an increase of $10 million from last year's budget will support the expansion of mental health youth and additional youth recovery services. That, for example, $7 million increase in Casa House expansion operations. That's Casa House, not Classic Classrooms, which was a separate item. And then $3 million for Youth Centers of Excellence. I want to, before I pass off to ADM Everington to answer in a bit more detail around this with some of the programming, I also want to address this tragedy when we see that folks, when we see families in a cycle of addiction, and that intergenerational trauma is very real. Addiction is something that is just so toxic in how it can affect family life. And so many of these young Albertans who end up in overdose and tragic deaths due to addiction, there are multiple generations involved there, and it reinforces, and rightfully so, with the question, we absolutely need to double down on our effort to break that cycle of addiction, not just with the children, of course, who are innocent victims in this, but also with the parents who are Albertans with dignity who deserve an opportunity at recovery as well. So that is a lot of what I'm planning on doing. So I'm going to go to my ADM to give some more detail on the children and youth piece to make sure that we get into the record a lot of the programming we have.
Thank you, Minister. Thank you, Chair. You're absolutely right. The Ministry of Mental Health and Addiction receives recommendations from the Office of the Child and Youth Advocate. We take those recommendations very seriously,
Chair, please.
Oh, sorry. We take those recommendations very seriously and ensure that we are responding. To the member's question about the overdose deaths and recommendations from the OCYA related to those deaths. In response to the OCYA recommendations, we have established the Virtual Opioid Dependency Program youth team. And this is a team that's dedicated to supporting youth receiving child intervention services with a specific focus on those in group care. So this stemmed directly from a recommendation from the OCYA. Also, just in relation to the question around element 2.7 from the budget and the child and youth programs that the ministry is making available to Albertans. We have the Mental Health Capacity Building in Schools program, which is offered by Alberta Health Services. This program works to promote positive mental health in children, youth, and families, and community members who interact with those children and youth. Each program is locally planned, coordinated, and implemented, and supports might include things like mental health promotion and prevention programming for students, referrals to community service providers for specialized services. They'll do classroom and school-based presentations, support events and campaigns targeted to students. So just a number of school-based mental health supports that are happening there. Included in this is supports within 17 schools on First Nations and supporting Métis settlements. We also have operated through Alberta Health Services or funded through Alberta Health Services, the Honoring Life program, which is really a youth life promotion and suicide prevention program developed to support First Nation and Métis communities by building capacity in mental wellness, resiliency, and healthy lifestyle promotion. The member had questions about CASA classrooms. So we have a number of those classrooms opening across the province and certainly an expansion there, which I think the minister spoke to earlier. And then we've also got to the question directly around the Integrated School Support Program, which is a comprehensive health model that provides children ages 5 to 15, again, in schools with prevention and early intervention wraparound supports. And there are expansions planned for that as well.
Thank you. And with the time remaining, I just want to clarify line 2.7. It needs to be clear, and I can understand the confusion. Because we front-loaded money from our Canada Health Transfer into forecast 23-24, it may look like there's a decrease, but in fact, when you look at it and read it, it's an 11.
Chair, please, Minister.
Yes, of course, Chair. So, Chair, if you look at it, you'll of course see it's an increase of $11 million.
Thank you so much. That concludes that portion. We'll move over to the government side for their questions.
Well, thank you, Madam Chair, and through you to the minister and his staff for joining us this late into the evening. This is we're hour 9 almost into our 9 hours of budget estimates. But to underscore some of your comments earlier, this is an incredibly important topic, and happy to.
Sorry, member, if you would just kindly clarify if you're going back and forth or if it's going to be block time. With the minister, if you could just. What's your preference?
We'll stick with the block.
Does that work for you, Minister?
It does, yes, thank you.
Okay, let's proceed.
Thank you, Madam Chair. Yeah, just reiterating how what important work that is going on in the ministry, and certainly happy to ask some important questions on some specifics. So I do have a number of topics I hope to get to here. I'm going to start with therapeutic living units. And so this is on page 103 of the business plan. And the second bullet mentions providing therapeutic living units and access to discharge planning and transition for clients in Alberta remand centers and correctional facilities. So we know that a significant percentage of Albertans struggling with addiction find their way into the criminal justice system and oftentimes have completed their sentence without support for their addiction issues and are released only to continue the destructive lifestyle of addiction and crime. As we see the ever-increasing concerns around public safety in our communities, much of it related to addiction issues, it just makes sense that we would look to utilize an option of recovery at the same time as a prison sentence. So we know that access to discharge planning and transitional supports underscores the commitment to continuity of care beyond the confines of the correctional facilities, and it involves comprehensive planning and coordination to ensure that those leaving the remand centers or correctional facilities have the necessary resources and supports in place to reintegrate into society. So of course, as always, through the chair to the minister, how does incarceration look different for Albertans with addiction? Accessing these therapeutic living units compared to the general prison population, and what opportunities will they have to access support that will help break the cycle of criminality and lower reoffending rates and pursue meaningful recovery? And through the chair to the minister, can you confirm how many therapeutic living units the province currently operates and how many more we can expect to have by the end of 24-25? And obviously, it's a very important topic, but I would like to switch topics for the minister as well through the chair and talk about cross-ministerial partnerships when it comes to our recovery-orientated system of care. And for specific reference, this is in the first paragraph of page 104 in the 24-27 Mental Health and Addiction Business Plan. It states that mental health and addictions works closely with health, public safety, justice, and social service sector ministry partners, all of which have an active role in establishing recovery-oriented services and policies for Albertans experiencing mental health and addiction challenges. I know heard the minister speak on the need for these partnerships, numerous opportunities, and would certainly agree that these are very important partnerships. So through the chair, can the minister please describe which ministries he is partnering with in support of the recovery-oriented system of care and the work that you're doing with those ministries? And also, why is a cross-ministerial focus necessary to accomplish the mandate of the Ministry of Health and Mental Addiction? So I think that's two. I know it's late, but I'm going to try to squeeze one more topic in here, Madam Chair. And that, of course, is related to police and public safety. This is incredibly important for me, living in the capital region, needing to take public transit sometimes. I have friends and family who work and live downtown who are also on public transit and oftentimes tell me they don't feel safe. And so it's very important that we get a chance to address this issue. I'd like to reference through the chair on page 105 of the business plan, outcome 1, key objective 1.4, states support initiatives to expand police services access to tools that support Albertans' recovery while keeping communities safe. So through the chair to the minister, what specific strategies might be employed in equipping police services with tools to support individuals in recovery and ensure community safety? What sort of situation would a PAC or HELP team respond to? And what community-based organizations are partnering with police services? So I was able to sneak 3 topics in there, and my block's running out, but just like to close by once again thanking the minister and his team for joining us tonight.
Thank you so much. Well timed. Minister, for your response.
Thank you, Chair, and I'll do my best to direct my comments through you. Thank you for your diligence on that point. So on the question surrounding therapeutic living units, and I'm very glad that it was brought up, Chair, because it's something that hasn't yet received as much notoriety and coverage, but is such an integral part of our Alberta model. I remember visiting the remand and correction facility in Lethbridge, speaking to the director, warden, effectively. And I asked, what percentage of the folks coming through your doors who are remanded or sentenced are struggling with a serious addiction? And the individual told me that it's probably 9 out of 10 indicates so on the intake form, and 1 out of 10 aren't exactly telling the truth. So it's if you saw a Venn diagram of those who Minister of Public Safety and Minister of Justice interact with on the other side of the law, and you saw the folks that end up in serious addiction, you would see near perfect overlap. And that's not a condemnation. That's just a recognition that we're going to need this cross-ministry, non-siloed approach to dealing with addiction. And so we have a group of individuals in our correction facilities that are disproportionately affected by addiction, that have had an intervention of sorts in the broadest sense of the word, an arrest from the police and a trial of some kind perhaps, and charges being laid against you, and perhaps even a sentencing. That is a serious moment in someone's life. Any one of us, along with any of our family members, ended up in that spot. They would also be in a spot. So the therapeutic living unit is what allows us, for example, in Red Deer, to take people out of the general population and let those individuals voluntarily say, I want to start working on recovery, and I want to do it now. And I had this wonderful example when I visited there, been there a number of times, just earlier this month, where the individuals there were transitioning out of the therapeutic living unit into the recovery center that otherwise wouldn't have been there had we not built it in Red Deer. And it was this beautiful sense of continuity of what is the continuum of care around recovery in the province of Alberta in action. I want to go and talk more about those in detail, but I want to just touch base about the second question that was asked through the chair by the member. And that's surrounding the need for partnership between ministries when it comes to ROSC. I think the best example of this in recent concrete policymaking, which has been a huge success as far as I'm concerned for my ministry, and that's the Recovery Navigation Center established in Red Deer when it came to the encampments. Encampments is such a euphemistic term. It is not like camping in Jasper on the weekend. There have been not just reports, but verified media reports of rape happening, violent sexual acts from people who are not even in the encampment, who are walking by, lacerations, violent acts, claims of extortion, claims in, pardon me, it was in Edmonton, not in Red Deer, the Navigation Center. Thank you for the correction. And so claims of, I mean, I think that we saw a Lord of the Rings style battle axe was taken by the Edmonton police at one point. We all saw those horrific images. This is not a safe place to be. And so the Navigation Center, the Recovery Navigation Center in Edmonton, allowed us to be able to partner with Service Alberta when it came to getting IDs, when it comes to virtual opioid dependency program in my ministry, when it came to connecting folks with short and long-term housing options in Minister Nixon's. So we see a lot of that coming together. There is no way that I'll be able to accomplish my goal in a recovery-oriented system of care in the silo of my own ministry. I'm going to need all of these different tools. And I want to, and just because I only have a limited amount of time, and they were all very good questions, address briefly this question around public safety. Public safety, Chair, is just such an important key aspect. Obviously, my ministry is not a criminal justice ministry. I don't want to become one. This is a healthcare ministry. And we believe from a health perspective that being in addiction is devastating. And we know the evidence shows that run its course, for example, in opioid addiction, will end in death if we don't get someone into recovery. Those two stark dichotomous options, Chair, are beyond comprehension if this is your family member in it. And so from a question of safety to that individual, the dignity of that individual is struggling, but also a wider community safety question is why we're building the model. And I'm happy to address further some of the things we're doing. And of course, moving forward with compassion prevention in the future will be a part of this broad set of tools we have.
That wraps up, excuse me, excuse me. That wraps up the government side. We'll head over to the official opposition.
Thank you, Madam Chair. Speaking of healthcare, that's a good segue to my next set of questions. I assume that we will continue to do block time. Per page 105 of the business plan, Madam Speaker, 500 plus contracts valued at over $1.13 billion will be overseen by the Ministry of Mental Health and Addiction. Those were contracts that previously fit under the umbrella of Alberta Health Services. The business plan states that it will be with AHS until spring 2024, quote unquote. Today, believe it or not, is the first actual day of spring. Madam Chair, what is the status of this immense undertaking, and will the minister please provide us with a timeline and next steps? Through the chair and to the minister, in the budget highlights, government referenced $1.55 billion total expense to continue building the Alberta recovery model. What is the breakdown to the minister through the chair of that $1.5 billion between addiction and mental health, and further between child and youth, adult and senior care? Considering that the Ministry of Mental Health and Addiction will be taking on this massive new mandate as the lead on the new mental health and addiction organization, I trust I may ask some questions regarding AHS service and program delivery, particularly in consideration that that transition will have, according to the budget 2024, have begun today. A study released in Molecular Psychology identified the required number of psychiatric inpatient beds to meet the needs of a population. 60 beds per 100,000 population was considered optimal, and 30 beds the minimum in high-income countries. AHS reports in their 2022-23 annual report that there are 703 psychiatric acute beds, and that this includes beds for both adults and for children and youth. So when we're looking at 703 psychiatric acute beds, that equals 15.8 beds per 100,000. When we take out the beds for children, it equates to 588, which is a rate of 13.2, less than half the minimum recommendation, Madam Chair. The average, by the way, in Canada is 30. Through the chair, what will the minister do to improve those figures when he takes over from AHS beginning today? There is a significant and dangerous backlog in psychiatric hospital units that puts staff and patients at risk. Through the chair, how long do people spend on a psychiatric acute care unit? Please provide mean, median, and 90th percentiles. Happy to take that information in writing if it's not available this evening. There are 5 standalone psychiatric facilities in Alberta. Through the chair, can the minister tell us the wait times to secure a bed in any one of those facilities? And does the minister plan to increase beds in standalone facilities and in community mental health? Where housing is exceptionally scarce and cost prohibitive, how is the minister advocating for increases to permanent supportive housing for a population that is at risk of harm, exploitation, and violence? Unfortunately, stigma continues to abound, Madam Chair, when it comes to mental illness, particularly with some of the psychosocial disorders such as schizophrenia and bipolar disorder. It is a population that is unjustly stigmatized and judged. They are at significantly greater risk of violence, of being the victim of violence, than being a perpetrator. But for all of the latest rounds of funding for affordable housing, I see a real lack of permanent supportive housing. I'm curious about how the minister is coordinating with some of his colleagues in seniors, community, and social services to discuss how we can better support folks living with serious mental illness. Back to the psychiatric acute care beds, I have a couple more questions on that front. Is there pressure to discharge mental health patients to unsuitable environments to relieve ER wait times? We know, of course, that the strains on the healthcare system, Madam Speaker, are dramatic at the moment. And again, mental health and addiction is taking on a significant new mandate. For a relatively new ministry, I hope that we are going to be approaching this new mandate with a great deal of rigor and discipline. But how is the minister going to be making sure that people are not falling through the cracks in that transition, where people are going to be, because of those strains and because of the limited resources, are not going to be kicked out into environments and circumstances that are not going to be conducive with their long-term well-being and with the safety of themselves and the community? Lastly, where is the funding for day programming, outpatient services, community and family supports, so individuals with complex mental illness are not isolated on their own and that their loved ones are not abandoned navigating a system that they are not familiar with?
Thank you so much. To the minister for the reply.
Okay, thank you, Chair, and I'll do my best to get through the questions. I want to start by talking about a previous question asked by members surrounding compassionate intervention. And so the policy framework is underway. We're working on that. It is something that we do remain committed to. I want to stress that the language around the government has mused, quote unquote, about moving forward with compassionate intervention is wrong on 2 fronts. One, there's no musing. We are moving forward with compassionate intervention. And secondly, there's nothing amusing about the idea of leaving somebody in -40 weather who has a drug-induced psychosis that could be from speedballing methamphetamine with an opioid, living on the streets in Edmonton, for example, in the middle of winter. There's nothing amusing about that. That is not the way compassionate society addresses the most dramatic crisis an individual can face in their life because of the physiological and psychological dependence on that addiction of the opioid. For example, many individuals with an opioid addiction will lose a fifth to a quarter of their body weight, and they won't eat because that desire to consume the opioid is higher than the desire to feed oneself. There's nothing amusing about that, Madam Chair, and we are absolutely serious about intervening to help those compassionately and not leaving them on the street. There's nothing more un-Canadian than leaving our fellow Albertans and Canadians and family members and community members there. And so we are moving forward. And of course, as mentioned, Chair, PCHAD and Mental Health Act do exist, but they are not suitable for someone who is a danger to themselves or a community because solely of their drug use. And that is what this act is going to be addressing. And I want to particularly in this moment, before I get on, quote Chief Crowfoot, who said this last summer as we partnered with them in the MOU signing for the building of the recovery community in Siksika when he was questioned by the CBC of all organizations. He said, quote, "Our way is to intervene. We are not raised to sit back and let somebody self-destruct. We want to be able to do something before we are going to funerals. We have individuals that are harming themselves and harming community. Why would we just sit back and say, oh, well, that's Johnny's choice," unquote. He continued on to say, Madam Chair, that what we're doing in the government isn't as far as he would like to see us go. But we will continue to move forward thoughtfully and in a balanced way to make sure we're intervening compassionately. I want to also address now some of these questions asked surrounding the questions of beds and the refocusing of Alberta Health. So, if you'll excuse me one moment. Last year, I did direct AHS to undergo a comprehensive expenditure review of services related to mental health and addiction. This was our first step in moving forward to the state we're in today, so that we had a better understanding of what programs are available through AHS at that time. And this was well-timed because as we came out of last fall and the decision was made by our government to move forward with the refocusing, we had organized in an organizational sense within AHS and also from a financial perspective in terms of looking at where dollars are being spent, a provincial portfolio of where we were within Alberta Health Services and what was dedicated to mental health and addiction spending. And that's where this 1.13 came from. Exactly how all those details look are things that we're working through with AHS right now, and exactly how that breakdown looks. And I can tell you, language around taking over is very, very, it's just not accurate to the situation and the tone and tenure of the relationship that my department and my ministry have with AHS. It is collaborative, it is forward-thinking, it is putting a new focus on mental health. So it's a partnership, and we obviously have named our transition lead, Carrie Bales, who was the portfolio lead within AHS before. It's a collaboration. It's one saying that there will be more mental health and addiction services going forward. And to the question surrounding beds, we want to see more expanded, of course. I'll let my Deputy Minister in the short time remaining answer some of those details as well.
Thanks, Minister. And Chair, yeah, absolutely. The focus with the refocusing work is to drill into that, to make sure that we can quantify the dollars that are in the system, as the Minister said on expenditure review, looking at the dollars and the appropriate bed ratios that are needed across the province. CIHI does report that median wait times for community mental health and substance use services is in the range of 19 to 17 days, so that is benchmarked.
Thank you so much. And now back over to the government side.
Thank you very much, Madam Chair. I would like to ask the Minister if he would like to stick to block time or...
Let's keep a good thing going.
All right. Sounds good. So as a parliamentary secretary to Indigenous relations, my question will be concentrating more on Indigenous file, as well as the treatment and recovery. And from here, I would like to personally thank you, Minister, for choosing the path and your team there to choosing path of treatment and recovery versus safe injection site, because I have a very, very close family friend who was an addict for many years, and now because of your treatment and recovery program is fully recovered and is now a compassionate member of our society. And according to his own words, if he would have choose safe injection sites, he wouldn't be among us right now. So thank you again from the bottom of my heart for choosing that path, because it's in my mind, it's the only path forward. So I'll start from Indigenous-led recovery communities. So under Outcome 2, Key Objective 2.3 aims to develop a comprehensive continuum of culturally appropriate mental health and addiction services to support Indigenous people in Alberta. Considering the disproportionate impact of addiction on Indigenous communities, it is evident that the province's addiction strategy is outlined in the business plan should encompass culturally appropriate support for Indigenous people in Alberta. We know that working collaboratively with Indigenous communities to develop actually a culturally appropriate mental health and addiction services is essential for promoting inclusivity, addressing historical trauma, and building trust, and also to improve overall well-being within these communities. It is acknowledged that a unique needs and strengths of Indigenous population contributing to the more effective and sustainable mental health support systems. In light of this, I would like to ask some of questions about how key objectives, specifically on 2.3, aligns with the substantial capacity building efforts undertaken in the province's initiatives to establish 11 recovery communities across the whole province of Alberta. So, with impact, my question will be, what impact will these recovery communities build in partnership with Indigenous communities have on the overall well-being of our population? What has the response been from the nations where you have committed to building these recovery communities? And how else is this government partnering with Indigenous communities to develop culturally appropriate mental health and addiction services? And the last one would be, how will these efforts contribute to the overall well-being and resilience of Indigenous individuals, families, and communities across Alberta? Next question would be kind of switch towards recovery supports in our communities. And the first bulletin on page 103 of the MHA Ministry Business Plan reads, helping more Albertans pursue recovery from addiction through increased access to medical, detox, and long-term addiction treatments. With the increased demand and severity of addictions in our communities, we need to expand capacity and access to these much-needed addiction supports. Shortening wait times and interim services such as pre-treatment and waitlist support that can help Albertans navigate more successfully our recovery continuum. Sorry, I've got a drink here. So the questions are, how has Alberta expanded access to addiction supports? How many people are served each year by these expanded spaces for detox and treatment in Alberta? Does government believe the space is already open for the treatment and the ones coming online?
That's your time, member. We'll turn to the minister now for his response.
Thank you, Chair. I appreciate that. And I'll do my best to get through the questions, all thoughtful ones. And thank you, through the Chair, for the member's work as a parliamentary secretary and the work he's done. A lot of what I do is only possible when we, as the government of Alberta and across the entire team, have good relationships with our First Nation partners in the province. So I'll start by addressing the question surrounding the importance of the cultural sensitive treatment spaces and capacity building, which I think was the item highlighted in 2.3 of the business plan. So we need to have capacity in order to meet the needs of the tragically growing number of Albertans suffering from addiction. And we're looking for more information nationally to understand if Safe Supply out of BC is contributing to that. So far, the federal government has not answered our call to put a unique chemical identifier in Safe Supply. In all likelihood, we hear anecdotal reports of that making its way into Alberta. Tragic, if so, contributing to the addiction that we have to deal with here in our own communities, in our own families. But that capacity piece is not focused exclusively just on the recovery centers. As you mentioned, there are 4 that are currently announced, with more to come with Indigenous partners. But we also partner, for example, with Oxford House, which is a part of this capacity building, Chair. So what we need to do is make sure that if we focus exclusively on the recovery centers, right, we need to keep them running as effectively and efficiently as possible, as was asked earlier. We need to have the ability through pre-treatment housing with groups like Oxford House, which is Indigenous run, organization that focuses on ways to try and create a flexibility in our system and the entire recovery-oriented system of care. And so that is one example of investments that we're doing to make sure that not only are we meeting those $99 million this year in budget for building those recovery communities on First Nation reserves, but also beyond that, looking in our communities and urban centers where so many of them reside, partnering with Treaty 6 in a big way, as we saw through Minister Nixon's as well, to make sure they all funnel into this direction. I want to also focus a little bit on the question you asked surrounding what we're doing to partner directly in mental health and addiction services. And so I want to let you know that there are a number of these different relationships we have that every one of these grants, every one of these positions that we're funding, every one of these relationships are due to work that members such as parliamentary secretaries, other ministries, and our premier have done to be able to have these collaborative relationships. So it's almost, for example, in this budget, $1.4 million to the Blood Tribe to operate transitional beds for community members awaiting addiction treatment or transitioning from treatment back into the community, $1.2 million to support First Nation client liaison positions with 4 health centers in the Stoney and Tsuut'ina First Nations. These liaison positions are incredibly important for increasing community recovery capital and partnering with those nations. $535,000 over 3 years till 2021 to 24 on the Kitaskanau Tribal Council to provide improved integrated coordinated mental health and addiction services. That includes Whitefish Lake Nation, Peerless Trout First Nation, Loon River First Nation, Lubicon, Lake Band, and Woodland Cree First Nation. $500,000 over 3 years to provide Métis settlement mental health and addiction navigators to work with improved access to mental health and addiction services for clients. Another almost $500,000 over 3 years for the Métis Nation of Alberta Association of Wellness, Community Wellness Advocates Program. Another almost $500,000 over 3 years until 2026 for the Addiction and Mental Health Program that focuses on the population of Grand Cache and surrounding Indigenous communities. I could go on with even more, and I think it's important to highlight that every one of those dollars spent, every one of those individually highlighted grants are more than just dollars and cents. It's more than full-time equivalents, FTE, as we say in government, of individuals helping navigate, connect through recovery coaches into the recovery program. It also signifies a positive relationship with our First Nation communities, Chair. And this is the biggest win, and we can build on that. And it's just so sad to see the federal government has been absent, not even showing up, not even putting on their jersey when it comes to the trying to help address in this field hospital we need to be as a province with the crisis that so many of our First Nation communities are dealing with. And so I think I'm going to answer some of the questions you had surrounding detox and other spaces at a future time. I'm very happy to continue in those conversations, and I think that this is an important piece.
Thank you so much. Minister, now over to the official opposition for their block.
Thank you, Madam Chair. My next round of questions is going to be in regards to overdose dependency programs. It includes the VODP program as well as narcotic transition services. Now, this is a file that it's a program that's kind of an interesting one. It does have significant kind of interfacing with the Ministry of Health in regards to the OAT gap coverage, OAT standing for opioid agonist therapy. And so it is, you know, with this new merger of all of the addiction and mental health departments under the umbrella of mental health and addiction, I think the minister will be able to handily respond to my questions here. The OAT gap coverage program only covers methadone and buprenorphine formulations, which includes Suboxone and Sublocade, for 120 days. This means that people who have not benefited from either of these medications or who wish to start on a slow-release oral morphine like Cadian can't access this program. The 120 days seems like a very concerningly short period of time where we know just how fragile recovery and treatment can be. 120 days amounts to about 4 months. What happens for those individuals who are accessing VODP, a program that this government, Madam Chair, has really lauded in terms of the uptake, and rightfully so. I think it has proven to be quite a successful program, but only for 120 days. What happens at 121? Madam Chair? What happens to those individuals who have come to rely on this very critical medication to avoid using more dangerous, unregulated, illegal drugs? And furthermore, why is it only covering methadone and buprenorphine formulations and not including Cadian? Cadian is recognized in every Canadian opioid use disorder guideline as a form of OAT, but for some reason it is not included. Considering that really the OAT gap coverage program, Madam Chair, is really quite a minimal expense to in consideration of all that is going to be within the purview of mental health and addiction in just a few short days, could the minister consider extending the period of universal gap coverage to a full year? This leads me to another set of questions around the kind of weird selectivity that the minister has demonstrated in terms of what drugs are okay and which ones are not. Madam Chair, methadone is an opioid. Hydromorphone is an opioid. Why is methadone included in OAT gap coverage, but hydromorphone is not? Why is the virtual ODP program provided in every corner, same day service, Madam Chair? You can make a call in the morning and you will have a prescription filled by the end of that day for an opioid. Why is it that VODP and ODP clinics are available across the province, but the Calgary zone with over 1.5 million people has one narcotic transition services program that offers hydromorphone? Why is methadone okay and hydromorphone is not? They are both opioids, Madam Chair. This kind of selectivity, in my mind, is costing lives. It is costing livelihoods. It is harming families. And I would like to hear, through the chair, why the minister is arbitrarily choosing.
Order called. Go ahead, member.
Thank you, Madam Chair. The point of order relates to 23H and I of the standing orders. The member makes allegations against another member, imputes false and unavowed motives to another member, that is the minister here. The member has made allegations detrimental to the person of the minister. The statement made by the member, though may relate to the functions of the minister, also relates to the personal matter, and this claim against the minister is unacceptable, Madam Chair.
Thank you so much. Opposition?
Thank you, Madam Chair. I don't believe, I don't have the benefit of the blues, but the member has said that the selection of drugs is what's costing lives, not the minister. And so at this point, I don't believe that it's a point of order.
I actually was going to call a point of order myself, and so I do find this to be a point of order. So, member, if you would kindly get back to the estimates, the reason for the meeting today, that would be sincerely appreciated. Thank you.
OAT gap coverage is absolutely a line item in the health estimates, as is VODP, but I will not pursue that line of questioning any further. I'd like to know why some drugs are covered and some others are not. Furthermore, I'm reading a report here that in 2022, the overall cost of substance use in Canada for alcohol use, Madam Chair, was $20 billion. That's lost costs in health, that's costs in healthcare, lost productivity, criminal justice, and others. Opioids, conversely, are 7.1. In the strategic plan, there was conversation about bringing alcohol sales, Madam Chair, into grocery stores and convenience stores. Alcohol, according to this data, is actually having a much more significant cost to our system than opioids are. I'm curious, Madam Chair, if the minister can speak to his thoughts on increasing access to alcohol that can actually have significantly more damage than opioids.
Could you please get back to the main estimates?
It is certainly considered within the budget that.
Please, if you could get back to the main estimates, just please kindly ask some questions of the minister regarding the main estimates. Your tone is reaching a higher pitch, and I just need you to bring it down and let's get back to the main estimates, please.
I would, through the chair, I'd like to hear the minister's considerations around the cost of alcohol abuse, please.
Would you kindly just direct your questions back to the main estimates? I've made my ruling, please.
I will cede the rest of my time.
Thank you, Minister. We'll hear from the Minister now.
Okay, thank you through the chair to the member for the questions. I'm happy to address all the questions asked. We started off talking about the virtual opioid dependency program. And so for reference, it's important to note that that program is approximately 8,000 unique individual clients that it was treating in 2023. It's a terrific program, and I want to thank, through the chair, members for being emphatic about the terrific success of same-day access. I've never heard a member of the opposition so full-throatedly support and sell the government's success surrounding a policy like that at Estimate. It's wonderful to see. I could not agree more. It is same-day access. No matter who you are, where you come from, you can get access to the virtual opioid dependency program, which is opioid agonist therapy. It is evidence-based, proven medicine that helps individuals overcome their addiction. And it does it in a number of ways. And this will be a good opportunity for me to address the very important difference between what is opioid agonist therapy and why it's successful and continued use of drugs and addiction. All right? So, and NTS speaks to this as well. For those who didn't follow, NTS is the Narcotic Transition Services. So importantly, Narcotic Transition Services is one, a transitional service. It's not indefinite use, right? It's very small. I believe it's under 200 individuals province-wide that access it compared to the nearly 8,000 that access the virtual opioid dependency program. The evidence-based medicine that we follow in this is not going to be affected by, Madam Chair, radical activists that would want to push, for example, the hydromorphone, as the member mentioned, in safe supply, which is an unwitnessed, mass-distributed, incredibly powerful opioid. That is 5 times more powerful than heroin. Zero transition is required in those programs. It continues to escalate. Diversion is en masse. Even the BC Chief Medical Officer of Health admitted to her chagrin, I would imagine, publicly in her own report, that it is quote-unquote commonplace to see now diversion happening of hydromorphone. And so we will not bring those policies to Alberta. In fact, those policies are illegal in Alberta. And so long as this government remains in power, they will continue to be illegal in Alberta. Sublocade, for example, the use of Suboxone in the injectable form is incredibly effective, and it now has the lion's share of the use of the virtual opioid dependency program in the province of Alberta because it has a number of terrific advantages. This tech, this use is just so effective on a number of fronts. First of all, diversion is really not possible in any meaningful way because the nature of the injectable is that it goes subcutaneously and forms a gel and is released over a period of approximately 30 days. And so the idea of diverting that is really not something, once the injection happens, that is commonplace anywhere. And literature internationally backs this up. So it also does a number of things. The molecular affinity for the Suboxone is higher than an opioid. So if somebody were to try and use a high-powered opioid, like say hydromorphone, in an attempt to get high again, the affinity is actually higher for the molecules of Suboxone. And so it prevents, in most cases, the ability to overdose or even get high. So the tech is incredibly helpful. It also manages for that 30-day period withdrawal. So there's lots of good reasoning, and we can refer to experts, including our very own Dr. Day, out of Panoka with AHS, our AHS lead on addiction medicine, that backs up why we have made those evidence-based policy-making decisions that is really leading the way. We're seeing other jurisdictions now transition away from methadone and use more commonly Sublocade, Suboxone, or even the film variety of Suboxone as well. And so I'm going to defer to my ADM to speak to some more detail around some of the other drugs mentioned, but we are committed to evidence-based policymaking when it comes to our pioneering same-day access, as members mentioned, Chair, virtual opioid dependency program.
Chair. You'd asked, the question was asked, the member asked a question about the 120 days for the gap coverage program. That can be extended, that 120 days can be extended. The idea is that it is enough time for individuals to get onto a supplementary benefits program. It's usually enough time. If it isn't enough time, then it can be extended beyond that 120 days, Chair.
Okay, and so with that, I'll turn the last seconds over to the chair.
Thank you so much. We'll head back to the government side for their questions.
Thank you, Madam Chair. And through you to the Minister. In the 2024 Mental Health and Addictions Business Plan, line 3.2 states, expand access to a range of virtual and in-person recovery-orientated supports to improve mental health and addiction care and support better outcomes for communities in need, including underserved, rural, and remote populations. Madam Chair, I'm from one of these rural communities, and unfortunately I grew up with two parents that suffered with addiction. Thankfully, one of those parents was able to receive recovery-orientated supports, and we were able to get one of those parents back growing up. And I'm hopeful that through this government's investment into this mental health and addictions that we'll be able to bring the second parent home back to family where they belong. So this is extremely exciting for me. As a nurse, I worked at Begani Nation in my riding as well, and it's a community that in my community we get to see front lawn libraries where you get to open up and take free books. In Begani Nation, those instead of filled with books were filled with free naloxone kits. And these naloxone kits were also something that we handed out for free within the emergency department. So this rural supports is very near and dear to my heart, and we know that folks living in rural and remote locations, they can have a different experience when trying to access support for mental health and addiction concerns. Thankfully, in the community I live in, Claresholm, we have one of the largest mental health and addiction centers, and I'm so grateful for that and the supports that are provided there. With expanding access to mental health and addiction support in rural and remote populations, we can ensure that all citizens have the opportunity to achieve better mental health outcomes. Now, through you, Chair, to the Minister, what is described in this year's budget to help rural and remote access to addiction and mental health supports? And which community-based organizations are improving access to support? Myself and the Minister, coming from a remote part of the province, we know the importance of how important these services are. So if you may share with the committee a bit of your version on how a family can access support when they need it, regardless of what part of Alberta they call home. Still looking at outcome, and then moving on to outcome 3 on page 106 of the business plan, I see a lot of reference to addiction and mental health supports being accessible. Of course, in a province could have the best designed and administered programs out there, but if they don't do residents any good, if they're expensive, cumbersome, and take a long time to access. Chair, through you to the Minister, could you please speak at a high level to the role that access plays, particularly in the instance of addiction and mental health programs? Right now, we're living in an increasingly digital age, with a more demand than ever for virtual programs or virtual program options. And key objective 3.2 on page 107 of the business plan recognizes this, reading, expand access to a range of virtual and in-person recovery-oriented supports to improve mental health and addiction care and support better outcomes for communities in need, including underserved, rural, and remote populations. Minister, through you to the Chair, at a high level, Minister, could you speak to the role that digital options play at your service delivery, or in your service delivery? And one of the services listed under Outcome 3 include the Digital Overdose Response System app. I'm hoping you could speak more about this app in particular. Once again, as we see in Business Plan under Outcome 3, Albertans have access to high-quality, person-centered mental health and addiction programs and services. We can especially relate this to the needs of rural and remote communities, which can be under-supported when trying to access affordable mental health care. As the demand for timely counseling support is essential for healthy families, we can see that access to in-community care can be difficult. The reference continues. Expand access to a range of virtual and in-person recovery-oriented supports to improve mental health and addiction care and support better outcomes for communities in need, including underserviced, rural, and remote populations. Chair, through you to the Minister, can you please describe what the delivery of virtual mental health supports can mean to Albertans everywhere in every corner of the province? And what is the rate of funding, and how many people have been supported so far across the province? And with that, Madam Chair, I'll cede my time. Thank you.
Thank you so much, Honourable Member. Let's move to the Minister for his response.
Okay, thank you for those questions, Chair. I'm happy to address them, and I appreciate, before I was in the role of Mental Health and Addiction Minister, my interaction was probably similar to most Albertans in that I had family members that were affected by mental health crises. I had family members and friends that were in active addiction, that were in recovery, that families had been devastated by it, and I understand how deeply personal it is. So I'll say to the committee through the chair that I appreciate that everyone wants to bring forward their questions, because they from all sides want to see a successful Alberta when it comes to addressing mental health and addiction. And whatever differences we have, I think that we have in common. And I appreciate very much the questions asked surrounding that. And rural is particularly close to my heart. I hear stories from my constituents, not different from members across this committee, of tragedies, and access is such a big part of that in rural Alberta. So we know we have a big task in front of us, and we have the start of a recovery-oriented system of care in this Alberta model, and we have a lot of more work to do to make sure everywhere in the province gets to benefit from it. Counseling Alberta is one that we doubled the funding for. It is meant to be an intermediary. If somebody is in crisis, it could be someone considering suicide, it could be not even depression, but feeling depressed, it could be anxiety, it could be walking from those difficult situations towards addiction. Whatever it is, you can get access anywhere in the province, Madam Chair. If you call 211, for example, or go to counselingalberta.com, you can get that access immediately in Alberta, and we're looking to continue to expand that. And so this budget's an important part of it. When it comes to addiction itself, we just spent some time talking about the virtual opioid dependency program. Same-day access, evidence-based treatment, not about enabling addiction, but about facilitating and moving towards recovery. And paired with treatment, opioid agonist therapy is incredibly effective. Any one on its own, it's less so. So we need to start with that wherever you are, with that virtual opioid dependency, Madam Chair. And we need to move towards those in-person capacities we have. The majority of our recovery centers across the province are not in urban centers. The majority are in rural Alberta. And we're going to continue down this trend, especially as we focus on those disproportionately affected in rural Alberta, disproportionately Indigenous who come from rural parts of our province. And that is going to continue. You asked, pardon me, Chair, it was asked at a high level for the virtual opioid dependency program and DOORS to be talked about at a high level. So when we talk about the DOORS, the Digital Overdose Response System, it's an app that can be downloaded on any phone if someone is an opioid user. And it's important to note that some people, in trying to create these firm lines, call this harm reduction. And some people say it's a part of the recovery system of care. I, for one, anyone who wants to get someone out of addiction is someone I want to partner with. And we will, not in an ideological sense, but in a practical, human, dignified sense, Madam Chair, support any policy that brings us to that end. And that's why we oppose so-called safe supply. But we will do all sorts of other items that some people across different parts of the aisle describe as harm reduction. And the digital overdose response system allows a user of an opioid, for example, to have that on their phone, and if they are not continuing to keep it live and interact with it, then automatically call to that location would be an emergency response where they could administer naloxone and give that person immediate treatment to bring them back from that edge of cerebral hypoxia and tragically possibly death. And so we're very happy to continue those kinds of programmings in the province, knowing that this is the kind of support that is absolutely essential. We talked about digital options, and it's not just a question of rural and urban when we talk about digital options, Madam Chair. It's a question of people in all different states of life, no matter where they're coming from. It could be that it's a physical location. You could live in the community of Lacrete or High Level or Manning or Peace River. In my neck of the woods, 7 hours from Edmonton, 5 hours from Grand Prairie. Or it could be that you're in the downtown heart of Edmonton, and you, for a different reason, have an obstacle in front of you from physically getting access to it. Which is why when we look at those digital options, the Virtual Opioid Dependency Program, VODP.ca, 211, connected to any phone, 24/7 availability, and Health IM, for example, are all different programs that we have that can give access, whether the obstacle is geographic or any other variety, because every single Albertan deserves that opportunity at recovery.
Thank you so much, Minister. We just finished your questions. We're now moving over to the government's official opposition. Go ahead.
Thank you, Madam Chair. I've got a bit of a grab bag here of various questions, appreciating that this may be my last opportunity. So thank you through the chair to the minister for kind of pinballing with me over the various documents. I did want to revisit a couple of questions that I think are incredibly integral to have answered this evening. One, going back to an original question, this is per line item 2.6 of the estimates, programs that reduce harm. I'd asked a question of the minister, Madam Chair, around the services that are currently offered and run by AHS in regards to overdose prevention sites and supervised consumption sites. Through the chair, I'll ask the question once more. Does the minister intend to close the overdose prevention site in Red Deer in line with the recent vote by Red Deer City Council?
Excuse me, honorable member, we are on main estimates.
And I referenced the estimate line item 2 points. I'm sorry, maybe I shouldn't answer that. I believe I am as well. Line item 2.6 is initiatives that reduce harm, Madam Chair. That certainly does include OPS and SCS. There was a decision put forward by Red Deer City Council that this would be looking at possible closure, and I'm curious if in the 2024-2025 estimate that it does include the further operation of OPS, and if the minister intends to maintain that program, that service. I would like to extend that question to all OPS and supervised consumption sites as well, Madam Chair. Will they remain open for the foreseeable future now that they will no longer be operated by AHS, but rather operated by mental health and addiction? I'd like to continue on to a question that I did not get a clear answer on in regards to compassionate intervention per page 114 in the fiscal plan. That's the capital plan section where there's a line item for compassionate intervention implementation intake and assessment centers with $5 million allocated in this fiscal year plus another $5 million in the following year. What is a compassionate intervention implementation intake and assessment center? How is the $10 million going to be allocated, and is there a complementary operational budget line to support that endeavor? A couple of other questions here. One is there's a $5 million line item in estimates, line item 2.9 for the Center of Recovery Excellence. This is an operating expense in budget 2024 for $5 million for a Center of Recovery Excellence. In the preamble in the business plan, the preamble states that a Center of Recovery Excellence will improve the quality of mental health and addiction service delivery in Alberta. I'm not clear what a Center of Recovery Excellence is. How will it achieve its target, and will mental health and addiction be the intended operator? My last question, Madam Chair, to the Minister, per key objective 3.3 of the business plan, I'll just recite that here. The objective is to evaluate and expand access to mental health supports to promote positive mental health, prevent severe mental health issues from developing for students with mental illness. Through the chair and to the minister, this government has made school, home, and community potentially and explicitly less safe with policies on transgender youth. How does the minister square that with the stated business plan objective? At that point, I think I will cede the rest of my time. Thank you.
Go right to the minister.
Hey, thank you for the opportunity to respond, and I'm happy to address these questions. So first off, when it comes to the drug consumption site in Red Deer, we take very seriously, and this is a broad statement across all municipalities, feedback that we receive from municipalities. The municipal council in Red Deer considered its options in front of it, had a very lengthy set of conversations publicly and privately. As a council, they engaged me after their vote and asked if we could have a meeting. I happily did so. And my plan is to respect the general direction of Red Deer, but what exactly that looks like is going to be a question of some conversation that we have going forward. And I'm happy to keep the wider public and Red Deer up to date as we go forward with that. We need to do some looking and have conversations with Red Deer Municipal Council and look at what options we have going forward to best respect the general direction. I said this many times before, that we take very seriously input from municipalities. And so that will, of course, be there going forward. When it comes to the drug consumption sites operated province-wide by HS, they will continue to be operated by the new mental health and addiction organization in the province of Alberta when that transition happens. And I'll just note from an earlier comment, Chair, that was made, when the business plan refers to spring, we're not referring to the spring equinox date. The season of spring, I think, is an appropriate way to understand that in the text, just for clarity's sake. When it comes to CORES, line item 2.9, I'm happy to address it. It's going to be a body that will require parallel legislation, and stay tuned for more information as we move forward, that is going to look at evaluating and assessing our system's effectiveness and efficiency when it comes to mental health and addiction, providing a lot of advice for us at an important evidence-based and driven level, so that we're able to, so that $5 million to establish CORES identified within our budget of 2024-25. And it's also an opportunity for us to showcase how Alberta is doing what it's doing, and be able to have a body that can give us public policy advice and be able to look in real time at what is happening in our system. Albertans are very keen to see us take mental health and addiction seriously. It needs to be evidence-based and evidence-driven policy making. We take that very seriously. We take that seriously by evidence of this ministry's existence and this budget, and these estimates are going through today to the massive expansion to, I think, the 7th largest ministry in the government and a dollar spent operationally. So we know it's important for us. We want to make sure that we have the appropriate backing and advice and information, and making sure we're looking at what the system's doing and that we're responsive to it as we roll out programming and policies. Now, when it comes to the question around compassionate intervention, as I said, we're working on that policy framework now, and we're looking at what it's going to look like in the long-term recovery long-term recovery model, making sure that we're integrated all the way through in the recovery-oriented system of care. Throughout the entire continuum, we need to make sure that we have the facility and the supports we need. And so the dollars are going towards making sure that we have that capacity there when the time comes. And of course, as I said earlier, we're going to be working very closely with stakeholders, because we are very serious about moving forward. We are committed to move forward in compassionate intervention legislation. And so I think I'm going to address, yes, a couple more questions. When it comes to vulnerable Albertans, those who are in minority groups, no matter what the reason, if you are somebody who needs mental health support or addiction support, it doesn't matter who you are. We have an obligation, and we are absolutely committed to supporting that. And so good examples of this are access to counseling in Alberta. There's no criterion you have to meet in order to be able to access it. As long as you can get yourself to a working phone or computer, you're there. And the province has built a system to have as low a barrier as possible. And so that is the first step as a fallback resource to make sure that everyone has access to what can be potentially life-saving support through counseling. And it's incredibly impressive, the work that's done. You'll note that after a number of sessions with Counseling Alberta, and potentially of no charge if that's where the individual fits in the sliding scale, that the goal is to, pardon me.
Thank you so much, Minister. That's your time. Back over to the government side.
Thank you, Madam Chair.
Thank you, Madam Chair. And we're in the last leg here. It looks like I'll probably be the last to ask questions here. So thank you for your time tonight, Minister, and for all of your staff. I know that for myself, I feel as if you've done a great job answering our questions. We've actually had the NDP cede their time in the last block here before this, showing that they had all of their questions answered. Minister, I'd like to thank you for really moving forward with this recovery program, sir. I know that for myself, as soon as you announced that you were going down this direction in your ministry, I know that for myself, I could see promise in this, and I really wanted to get an idea of where my constituency sat, and really they were very supportive of you, to the point where they actually went to Edmonton, and you met with them, sir. And to hear some of their concerns about mental health and up in our area. And I'm very thankful for that, because it shows how proactive you are. You're trying to deal with this. One of the questions that kind of comes up with this is that when I'm talking with my First Nations and my municipal partners, it doesn't seem like any of them are asking for safe supply. They're looking for recovery centers. It seems strange that this is something that the NDP would be advocating for, is the safe supply, when it appears that almost every municipality in Alberta is having issues with this narrative that's coming forward. Now, getting back to this, I'd like to focus on line 2.6, sir, page 165 of the estimates. This specific line highlights the allocation for initiatives that reduce harm, encompassing funding support for supervised consumption sites, overdose prevention sites, and the provincial naloxone program. Noteworthy is the projected increase in funding for the programs in the 2024-2025 fiscal year. The estimate indicates a substantial rise to over $5 million, from $30 million to almost $36 million, sir. The question that I have is, since this line encapsulates what are commonly referred to as harm reduction or harm production sites or programs, could you please indicate whether or not the flagship initiative of harm production, also known as safe supply, is included in this funding stream, sir? And I will cede my time for the rest of the evening to you, sir.
Okay, go ahead, Minister.
The question, I'll be abundantly clear. Alberta has made illegal, through the chair, Alberta has made illegal safe supply. It will not happen. It's a failed policy in every jurisdiction. Canada, currently under the Trudeau Liberals, is the only jurisdiction offering en masse the most radical policy in the globe. There is no good evidence to show that it helps. And you don't need to only look at the data to see that. You can look at the streets and understand the human cost of what this policy is. And so I'm not going to speak for members opposite. Here, I will say that if you continue to advocate and use language like a toxic drug supply, anyone that does that is making an argument that a safe drug supply is a solution. If you continue to advocate, as anybody in the province can see, if you continue to advocate for drug consumption sites in every corner, no dollars invested into recovery in any serious way, and you look to, say, examples like BC for how we ought to be organizing our addiction response, then you will not help anyone get out of addiction. You will condemn individuals to this tragic, tragic existence of facilitating addiction to the point where either they find their own way out through no help of the government, God willing that's the case, or instead, Madam Chair, sadly it leads to death. And recognizing that tragic reality is exactly why this government has made it absolutely impossible. The Alberta response to addiction is about a recovery-oriented system of care, the Alberta model. That model is trying to capture all the different resources we have. Of course, we're going to prohibit safe supply, but it doesn't work if you don't have hope as well. the personal hope one has, the possibility of overcoming an addiction, if the government is sending a message out in every advertising corner they find, every program that they fund, and everything you hear out of every politician's mouth is, just go find more drugs, you'll be fine, then it kills hope inside an individual. But if instead, if there is a positive message that says, you are an individual with dignity, as an Albertan, as a Canadian, we care for you. We want to see you succeed in life. We want you to be a brother and a mother again. We want you to connect with your family, your children. We want you to have a job. We want you to be a community volunteer again. Then that tells them that they have dignity and value. And the words we use in government, like toxic drug supply, can be condemning to an individual when they're struggling with an addiction. Or words like recovery can be uplifting and providing a hope that is unparalleled when you're in the lowest doldrum of what feels like an enslavement to the drug, where there are shackles around your arms and legs and you're compelled to continue. That difference starts in committees like this, in legislatures like the one we all belong to. That difference isn't just policy. That difference is a cultural shift in the last 30 years of abject failure from the Western world surrounding addiction. And Alberta is leading the way, and I couldn't be more proud of that.
So much, Minister. I must advise the committee that the time allotted for consideration of the ministry's estimates has concluded. And I'd like to remind committee members that we're scheduled to meet tomorrow, March 21st, 2024 at 9 a.m. to consider the estimates of the Ministry of Children and Family Services. Thank you, everyone. The meeting is adjourned.